Hello, everybody. Welcome. We're so happy that you're all joining us this morning. We're trying to give everybody a couple minutes to come in from the waiting room. So I just wanted to say good morning to some, afternoon to some, and even evening for some of you. And thank you for joining us today for the Scleroderma Foundation of California's Virtual Patient Education Day with the experts from Cedars-Sinai Scleroderma Program and Clinical Center of Excellence. We're thrilled to bring this educational forum to your living rooms while you hear from several of these experts who will provide an overview on CEDAR's clinical and research program, clinical and research updates in scleroderma, ending with a great overview focusing on GI symptoms related to small intestinal bacterial overgrowth in scleroderma patients. I'd like to personally thank Dr. Boiin, Dr. Bottini, Dr. Rezaie, and Marianne for taking time out of their busy schedules to be with us on a Saturday to provide us with extremely important and helpful presentations to scleroderma communities near and far. Because of all of you, our scleroderma families listening today will be able to put on what I call the scleroderma suit of armor, and that's to gain knowledge, make informed decisions relating to their care while holding their healthcare team to a higher standard when they're unable to see scleroderma specialists like yourselves. On a personal note, I was reviewing the registration list for today, and I learned that many of you that are joining us today, you're newly diagnosed men and women. And I felt it was important to make sure that you know you're not alone and that we're here to support you in every way that we can. We want to provide you with the best guidance and resources to help you live successfully with a chronic illness like scleroderma. So even if you're not from a location that our foundation serves, or you're not familiar with your local organization or support groups, I'm happy to provide you with the information to seek that support from your parent organization. My motto has always been, it doesn't matter where you're from. I just want to make sure that you have the tools and the support that you need and deserve to effectively navigate this often difficult disease. I want you to feel empowered and equipped to live your best self with scleroderma in it. I'd like to introduce the Scleroderma Foundation's Executive Director, Andrew Emmett. He's going to say a few things before we go over some housekeeping items, and we're going to introduce our first speakers. Andrew?
Good morning, everybody. Welcome to our 2022 Education Day. I want to thank Tina for putting together such a great presentation today. Our doctors from Cedars-Sinai, thank you for being here on a Saturday, and to all of you here watching the webinar, thank you for coming, and thank you for your participation. It's hard to believe we're kind of at the end of the year here, and this is our second year doing virtual patient education days, and I'm looking forward to next year when I think we're going to be able to get back and do one in person, and we'll be able to see each other and gather and communicate as a group in person. So we look forward to that next year. I wanted to thank everyone who has participated in our Bark for a Cure pet photo contest. This has been the most successful year we've ever had. We're almost at $16,000, and there is a bidding war going on to be number one. There's a couple, four or five pets that are jockeying positions today. So you have till 6 p.m. And if you haven't voted for a pet yet, please consider going to our website, looking at Bark for a Cure, and voting for some of the pets that we have there. There's an amazing group of 25 pets. And finally, I just wanted to say thank you to Tina. What a great job. As we have transitioned into an independent organization, we are providing support groups throughout the whole state of California. We've grown our support groups by 6 since our transition, and we are the only organization with support groups throughout the entire state, including we have partnerships with some independent groups, and we are expanding in the new year. So stay tuned. We've got a lot of great stuff. And I didn't want to take any more time, so I'm going to turn it back over to Tina, but I just wanted to say thank you to everyone, and especially our partners and our sponsors. So Cedars-Sinai, we could not have done this without you. Thank you. The Capital Group for program support, and the Tina P. Waxman Foundation. Thank you so much for all your support. We couldn't do it without you. Thanks, Tina.
Thank you, Andrew. I want to remind everyone that the Scleroderma Foundation of California does not endorse any specific treatments, drugs, or research trials. And because scleroderma affects all patients differently, treatment approaches that may be appropriate for some patients may be less suitable for other patients. Any treatment decision should be based on knowledgeable discussions between patients and their clinicians. After each speaker finishes their presentation, we're going to have 10 to 15 minutes of Q&A from the audience. Please remember to wait until they finish typing your questions in the Q&A box. That way we can avoid weeding through questions that might be addressed during your talk. I will read your questions aloud to the speaker in the order received. Also, after the last speaker finishes his presentation, we will open the floor again for 30 minutes to allow our audience to ask questions to any of our speakers in a group panel before closing for the event for the day. We've also included a survey at the end of the presentation, and we hope that you'll take the time to provide your personal important feedback. There will also be an additional opportunity to fill out the survey that will be sent to you in an email that you registered from. And now it's my pleasure to introduce you to our first speakers, Dr. Francesco Boin and Marianne Bernardo, who will be providing an introduction to the Cedars-Sinai Clinical and Research Program. Keep in mind that once this overview finishes, we will not open the floor to Q&A just yet, because Dr. Boin will immediately start his next presentation on clinical updates in scleroderma. Dr. Boin is the chief of the Division of Rheumatology and the director of the new scleroderma program at the Cedars-Sinai Medical Center in Los Angeles, California. Previously, Dr. Boin has established the University of California, San Francisco, UCSF Scleroderma Center, and has served as the director of the Translational Research Program at the Johns Hopkins Scleroderma Center. Dr. Boin is an accomplished clinician and investigator with extensive experience in the diagnosis and treatment of scleroderma and other fibrosing skin disorders. His research is focused on the genetic risk and role of immune cells in the pathogenesis of scleroderma and lung complications. He also has established and currently coordinates in partnership with the National Institute of Health, the Genome Research in African American Scleroderma Patients, GRASP study, a multi-center consortium involving 25 U.S. academic centers aimed at discovering key changes in the DNA of African American patients that may explain their increased risk of developing scleroderma, as well as the more severe clinical manifestations. Marianne Bernardo joined Cedars-Sinai in 2021 as a research manager with the Division of Rheumatology. Her focus is managing the translational research unit from an organizational, regulatory, and budgetary standpoint. She is certified clinical research professional with over 10 years of patient-facing research experience. Throughout her career, Marianne also worked at UCLA, where she managed a central clinical research team that supported multiple divisions across the institution for a number of years prior to joining Cedars-Sinai. Marianne was drawn to her current role by wanting to make a positive contribution in the field of rheumatology research by helping to build the largest prospective cohort of scleroderma patients. In her free time, Marianne enjoys going to the beach and spending time with her family. And without further ado, please join me in welcoming Dr. Boin and Marianne. I'm going to share the screen, so just give me a moment while I highlight them and I take the highlight off of Andrew and I.
Okay. Good morning, everybody. I hope you can see my presentation here on the background. And I thank Tina and Andrew for giving us the opportunity to be here with you today. It's a real pleasure, and we are very excited to spend this morning with you. We felt that the first part of the morning should be introducing you what's going on at Cedars with regard to scleroderma. There is a lot of excitement and momentum as we have established a new scleroderma program in clinic, and I think it's important, that those who are still there looking for experts and places where their disease can be helped, that they know that there is also this possibility, and it is up and running with a lot of momentum. So I will start the presentation, asking the question, why a scleroderma program should exist? Why a scleroderma program at Cedars-Sinai? Well, the simple answer to that is that the reason we have a program is to alleviate the suffering caused by scleroderma and to find a cure. Obviously, this is not an easy task, right? So I always think of finding a cure or tackling scleroderma as a challenge to go on the top of a mountain. This is K2, the second tallest mountain in the world, and arguably probably the most difficult technically to climb. And so when you approach scleroderma, sometimes I feel, yeah, we are in front of a mountain to climb, and there are many ways you can think of going up to the top. But I put myself in the shoes of this little guy you see on the bottom here on the left. This is not a goal that you can achieve just alone. It's too big. And I think also, looking at what it takes to get up among K2, you see here there are, a lot of people that will support the climbers, will support the effort to succeed on climbing the mountain. And so similarly, working on a disease so complex and difficult as scleroderma, you need a team effort. You need to be, working on this together. And the partnership is not just the physicians or the people that do research or the clinical team, but also, the patients themselves. And I can be clear enough to say that I always found that my patients have been great supporters of everything that we do, from promoting the scleroderma program, from participating in the research. So it's really a team effort, and I think we are on this together to make better ways to diagnose, manage, and treat scleroderma. So the concept is very simple. Why a scleroderma program? Well, the concept is to know the disease well, so that we can provide the best care, and around that to find a better cure. And I think Cedars-Sinai convinced me to come. As Tina said, I've been working on scleroderma for the past 20 years of my career. But Cedars-Sinai really make a strong argument that it has what it takes to put together the key pillars to have a cutting-edge, comprehensive scleroderma program. And this revolves around the clinical care, as we just said. We want to provide the best care. This involves, expert physician who knows the disease, that they know the challenges of this disease. To have a dedicated clinical infrastructure, you need a team of people that take care of patients before, during, and after their visits. And then, the ability to build a multidisciplinary network. This is not a disease that have only one problem. It's multiple organ, multiple problems. Second, the science. You would not break through, make advances if you don't match the clinical care with top scientists. And we will hear about some of our effort to really provide the best environment for science to thrive. Top scientists that can really accept the challenge of bold ideas, the new ways to really think about a disease, to create collaborations, and allowing us to build a cohort with a refined database and samples, and to venture into clinical trial eventually to really test new treatment. And I don't want to undermine I would like to underline the importance of education, awareness. This starts by, for us at least, awareness starts from inside. New doctors, we want to train new rheumatologists, new doctors, to educate internal medicine doctor about scleroderma. Oftentimes, and I'm sure most of you experienced, doctors say, I don't know what's going on. They don't have experience, and I think it's very important. Our mission is also to increase this awareness, and the connection with the patient is critical for this, and also embarking into outreach activities. So it's very important to underline that all this new initiative at Cedars-Sinai is being made possible by a very generous gift from the Cow family and the Cow Family Foundation that really had the vision to invest on an institution like Cedars-Sinai to create a program that revolves around scleroderma, to establish an autoimmunity institute. We will hear more about it, to provide connection for the best possible research, so not only the clinical care, but also the research, and then to allow academic growth of the Division of Rheumatology. So we're really grateful for the continued support that we're receiving, and I think this goes beyond us as a program, but it will benefit. We have no doubt that this will benefit the entire community of scleroderma patient around the world. Now, let's talk about the clinical side. So we see patients here. I wanted to quickly highlight our clinical operations. So we see patients at the Steven Spielberg building. This is on campus where the Cedars-Sinai is. Some of you are familiar with this. It's a work in progress, meaning that we are renovating the space. There will be new signage outside here that will identify us as a scleroderma program. And inside, this is the projection of how our lobby will look like, really nice. It will take some time, but definitely we are excited that we are also giving a brand new space where we can host all the scleroderma clinical operations. Now, when you come here, you're gonna see smiling faces. Actually, there is under the mask. Actually, we still are mandated to use, but there are definitely smiley faces. And so we are assembling the team. We've been assembling the team, and so we have a dedicated scleroderma nurse, Lauren, who is gaining expertise, understanding the challenges of scleroderma, and is becoming a very precious partner for the physicians that work in the scleroderma clinic. And then we have patient coordinator, Andy and Mary, critical for us for the intake of patients. So if you're gonna be referred here or would like to come here, these are the two people that will interact with you to get all the records, and they assist us to be sure that we are ready to see you at the best. But also being a point of reference for any question after you have been seeing at Cedars-Sinai. And then Sayira, that is our medical assistant, that certainly is the most gracious person to help you throughout your stay during the visit. And then the physicians. So I started by myself, and we were lucky that Dr. Bottini decided to join us, so he would be a second physician seeing patient with us in the clinic. And we have a rotating fellow with the idea that hopefully one day we will have some permanent fellow, meaning junior people that we want to educate and commit, that they decided to commit their career to scleroderma. And this is, will grow, will continue to grow and strengthen based on how much volume of patient we will bring on board. Now, another important aspect to why Cedars-Sinai is a special place is that truly to take care of scleroderma, it takes a village. This is not just the skin problem. Every single organ can be affected. We will talk about that in the clinical talk. But to really deliver the most effective care, you need to be able to address problem in any kind of discipline. And so we started from day one to connect within the bigger institution of Cedars-Sinai to doctors that we know can be helpful to our patients and to streamline connections. So by coming here, we are able also to leverage expertise in the lung, on the heart, the kidneys, the gut. We will hear from Dr. Rezaie today, the motility program. He's the head of the GI motility clinic. Lung transplant, we will talk about that a little bit, and so forth. So I think, truly we cannot be successful if we don't have an integrated network of specialties supporting the work that we do as rheumatology. We are sort of the quarterback, and then we help integrating this care. Now, the goal is really not only to take the best care, but also to unravel the mysteries of scleroderma. Why is it so complicated? We know that there are possible multiple triggers that probably don't work in isolation, they work in combination. There are environmental factors, infection, the underlying cancer, the genetic predisposition. So this creates a complexity in terms of what triggers scleroderma, but also determining different patterns of how the disease manifests. There is fibrosis, the scar tissue, but when people that sees me, I always tell that scleroderma has two souls. It has the scar tissue on one side, and the other is the vascular damage, and the two are connected. And in different patients, one is more important than another. And then this is all put together by this autoimmune process. This is a process where the immune system damages the body. So try to understand all these different components is not easy, but that's why one of the major goals that we have is really to build a large cohort of patients. So think of scleroderma like these apples, right? It comes in many different flavors, different colors, and if you look in general, it's hard to tease out the different type of scleroderma or the different type of manifestations. And so, by having a large cohort of patients, one side is and the experts that we need allow us to do refined clinical observation, right? We can start to figure out, oh, there are unique flavor, there are unique type of scleroderma, unique type of manifestations. And we can go deep, not only by looking from the outside, but when we look in the inside. That's where, the research is so critical to understand why there are these different flavors. But then on the broader scale, the number of our patients in our cohort and patients who sees me, they know we ask to be part of our cohort precisely to be able to have big buckets. So, once you identify the flavor, we want to have many of these different, and then compare them. And that's the goal of having a database, a clinical research, understanding if there are flavors that predict certain type of outcome or complication down the road. And so ultimately, this is the foundation of what can help us to make discovery at Cedars-Sinai. And I won't spend much time, but part of the vision of developing a scleroderma program at Cedars-Sinai was to connect that with cutting-edge research and the establishment of the Cow Autoimmunity Institute. And I apologize, there is a typo there. It's autoimmunity, not autoimmune. Is critical because we have the possibility to aggregate the best possible scientists. And you will meet Dr. Bottini, is the new director. We are very excited that Cedars-Sinai successfully convinced him to come from UCSD, and he will lead the group of people that will make discoveries and breakthrough in scleroderma. And then obviously to enable all this operation that goes from the patient-facing activity to the bench, we also established a translational research unit. And I let Marianne Bernardo, is our research manager, to sort of introduce to you how this unit works and how important it is to really glue together the clinical operation with the research operation. Marianne.
Thank you, Dr. Boin. Hi, everyone. As Tina mentioned earlier, my name is Marianne Bernardo, and I'm the research manager for our translational research unit, or what we call TRU sometimes for short. And so I just wanted to give a little introduction on what our team does from a patient-facing research perspective. So on the next slide, one of our focuses actually in the TRU is what Dr. Boyd mentioned, is helping to build prospective cohorts so that we can learn more about certain diseases such as scleroderma. And so this slide shows here one of our research coordinators, Meilani, consenting one of our patients into our scleroderma cohort. And to participate, the process is really simple. We consent patients in a private exam room, and the consenting process usually occurs during our patients' routine clinical visits. So we try to make it as seamless and convenient as possible for them, so it doesn't take too much additional time out of their day. And so when we go over to the next slide, once a patient is consented and enrolled, data and sample collection are done. And this usually also occurs on the same day. And so the data that we are collecting from our patients are in the form of questionnaires. And then as you see here in this slide, our nurse Lauren is collecting the blood samples. And so once collected, this allows our research team to process and organize the sample, match our data analysis, and then it enables us to do a deeper research. And then on the next slide, this shows our research coordinator, Brian, entering the data we collected from our patients into our database. And our data management is important because once our cohort starts to really grow and get larger, we want to keep it well organized. And so we designed a specific database for our scleroderma program, our cohort, so we can systematically enter data and make it a streamlined process for our research team. And so, what we always mention, sorry, going back to the previous slide, what we always tell our patients is while we can't provide results right away and joining our cohort may not directly benefit you now, I think our hope is that with the data that we collect, it helps researchers learn more about the disease and possibly find more treatments that may help you or others in the future. So we're always so grateful and appreciative of your generous availability to participate in our cohorts. And so lastly, with that being said, this goes from, I wanted to talk about our clinical trials. So from our, similar to cohort, this is more of now from bench to bedside. And so our translational research unit, we have the infrastructure to run some of the best clinical trials. And this gives us, it really gives us an opportunity to provide therapies or treatments that we think are promising. And so we have one active trial and one that we just completed called the Aurora trial, which we're still awaiting results. The active trial, the focus is on patients with scleroderma associated with interstitial lung disease, or ILD. And some of the eligibility requirements to participate in this study are disease must be 5 years or less, presence of ILD, and other features of severity, including high inflammatory markers or positivity of antibodies specific for scleroderma and lung involvement. So this is just some of the eligibility criteria. So if anybody here is interested in hearing more about the clinical trials or even our cohort, please feel free to reach out to me or one of our study team members for more information, and we'll be happy to provide more information to everyone.
Thank you, Marianne. So this is great, and again, highlights the commitment that we have to really make sure our patient has the best experience also as they participate into our research project and plans. As far as the clinical trial, obviously, we're going back, we're just started, so there will be many more that will come available. And, I want to point out that if we decide to embark into trials, we always scrutinize them to be sure they are scientifically the best possible trial with the best possible, future treatment. So to be sure that if we propose or offer you the possibility of a trial, if you're interested in participating in a trial, you're getting into something that we deem to have merit and hope that it may be a new breakthrough. I just want to point out that in terms of the ongoing research program, we'll cover many areas. I won't spend much time. Dr. Bottini will cover some of it, but we look at, if there is a genetic predisposition for scleroderma, environmental exposure. We focus on unique manifestations that we think they are more relevant in determining morbidity and mortality in our patients, such as, lung disease. We have an interest on vascular manifestations. We do have some projects that look at the immune system, what goes wrong on the immune system of scleroderma patient, and the mechanism of fibrosis of the scar tissue. Again, we will hear more from Dr. Bottini. And I want to conclude here saying that about the education that our faculty is really engaged at different level to really foster education on scleroderma. So that means to give lectures. We give lecture around the country and the world. We were just in Philadelphia last weekend where we were able to showcase our program. Publications, so we write textbook chapter, the articles that we do about our research. And then training of any medical student, residents, fellows. We definitely have that as a major commitment, as I said before, to be sure that the new generation doctors will know more about scleroderma. And in clinic, there are handouts that we prepare to help managing symptoms and manifestation better. And ultimately, we will try to develop a better presence on the web, on social media. Webinar like today are hopefully will be repeated, and we are committed to periodically giving updates and engaging the community. So to conclude, this is what's going on at Cedars. It's an exciting time for us, and we look forward to continue strengthening and further developing our scleroderma program. Our clinic is open. We have a lot of bandwidth to see patients. Right now, there is virtually no wait time. And so it's a good time to come on board, or if you know anybody that need help, definitely this is an easy task. This is the phone number to call and ask to be connected to this Scleroderma clinic, and some of our coordinator will guide you through the process of coming to see us. And so it's located, near West Hollywood and Beverly Hills, easily accessible from north, from south, 20-30 minutes from the airport. So many ways to reach us, and we will be thrilled to be here to provide to deliver the best care and to give you the help that you need to face the challenges that scleroderma poses. And so I stop here. I use this slide. This is Minaret Lake, my hiking expedition last summer. Sunrise. That's the way I see things here at Cedars. Is a moment of a new dawn. And I think when you see a picture like this, give you some optimism that we can work together. That we can take care of you. We don't have a cure yet, but we know we can take care of you and your problems. And thank you for listening. Okay. So as Tina said, we won't have question right now, but we can always do that at the end of the morning.
Correct.
I want to switch to the clinical updates. So in that way, without further ado, let me put it here. Okay. Tina, can you give me an okay that everything looks good, that I can move forward? Are we on schedule?
Yes, everything looks good. We can see your screen well. Thank you.
Perfect. Okay. So let's talk about some clinical updates. I will focus on some specific manifestations, but I wanted to start from some important concepts. The first is that, scleroderma is a disease of many faces, and that means that every scleroderma patient is unique and special. People are not experiencing the same type of disease. It varies, and everybody has a different type of challenges. Importantly, scleroderma, it's a multi-organ disease. So it's not just the skin, but any organ can be virtually affected. It goes deeper than the skin and our challenge is always to figure out what's the combination of the manifestation. But organs are more affected, and every patient, and some patient would have more damage and complication on one system, others on another. So this poses a challenge. So we know that classically, scleroderma is divided into limited and diffuse, which is based on the amount of skin that is affected. And certainly people feel, the amount of skin or the diffuse skin involvement is more kind of dramatic. Here on the blue line is the timeline of how the skin manifests, and you can see that the diffuse skin early on is more aggressive. But what's important to remember is that both limited and diffuse have internal complication that manifest at different time points during the development of scleroderma. And you can see that particularly early on in the diffuse skin, the skin goes deeper, get into the joints, the contractures, lung disease manifests, some people develop renal damage, the heart can get affected, and then on the long run, pulmonary vascular disease, pulmonary hypertension, and severe GI disease. So it's a multi-organ disease, as we pointed out. But the important concept I want to stress here is that there is an early phase that is very critical. There is a window of opportunity where we can really tackle ongoing damage before it gets irreversible, before the damage of different organs becomes irreversible. And usually this is the first 4 to 5 years from the onset of the disease. This is very precious, and I try to represent it here. These slides want to emphasize that we have to sort of be aware that disease onset and clinical onset are different. Disease onset happened much earlier than when the clinical symptoms manifest. So we call this the preclinical phase. So after the disease is triggered, there is a phase of no symptoms, and the patient don't know that they have the disease. And we don't know, does this last months? Is that even years in some cases? But then at some point, you know, the Raynaud's develop, or the puffy fingers, or some other symptoms. And so that's where we have what we call the clinical onset. What's very clear to us is the damage started from before. So by the time the disease starts, there is already ongoing damage. And so it's very critical for us that as soon as, because the damage is already ongoing, as soon as the disease surface, we need to be ready to diagnose it and to treat it, precisely to stop this process that will bring more damage. And so one of the major clinical updates is really this concept of early diagnosis. You know, across the world, we are, you know, trying to define what are the criteria, how early can we diagnose scleroderma? We don't want to wait until the heart and the lung are severely damaged. We want to start early. So just to give an example, early diagnosis really means early treatment. So for example, the patients who present with just Raynaud's, no skin disease, just the Raynaud's phenomenon, the cold sensitivity on the hands. They have, you know, some of you saw that we look at the nail fold capillaries, you know, on the digits. So they have abnormal nail fold capillaries and perhaps a positive antibody that is typical of scleroderma. So those patients have 80% chances that in a variable time of 4 to 6 years to have definite symptoms of scleroderma, definitely diagnosis of scleroderma. We call this very early scleroderma. And so this is the kind of patients that for us are becoming critical. There will be an effort to identify earlier the disease, not waiting until it's so advanced that we know that we can treat, but there is a component that will not be reversible. And so it's interesting, our friends in UK, the Scleroderma Foundation, Raynaud's of UK, did a phone survey to 400 scleroderma patients. You look at it on the left here, and they asked the question, if you were told that you have 50% risk of developing scleroderma within 18 months, would you consider being part of a trial for preventing scleroderma, meaning taking a drug to prevent scleroderma? And 88% say yes, we would. Knowing what scleroderma is about, if we have a way to say, oh yeah, in 18 months, in 1 to 2 years, you're gonna develop full-blown scleroderma, I would definitely do a trial. So this is really a message that you guys deliver to us, is this diagnose it early and treat it early. And so we will be developing, you'll see more what we call a scleroderma prevention cohort, meaning people that don't have already scleroderma, but they are moving in the direction. And we will probably consider early disease clinical trials. So we're not gonna do clinical trial when there is already a lot of damage, but something early on. Again, with the concept that if we are smart and effective in identifying the disease early, then we can implement better treatment. So I think when we talk about clinical update, this is where the field is going. This is where we are committing our energy. We don't want to have to deal only with irreversible disease. We want to intervene early. Now, talking about different organs, you know, we said any organ can be affected, but obviously some of them are more relevant. And always say lung and heart is where the money is in terms of what's happening, what to expect when you're diagnosed with scleroderma. If the heart and the lungs are affected, the outcome changes dramatically. And depending on the severity, you know, this may even impact the survival. So I wanted to talk this morning a little bit about pulmonary fibrosis, also known as interstitial lung disease, ILD, because this is an area where the past couple of years there's been some interesting breakthrough and updates. Now, here this is a CAT scan of the lungs of a patient with early disease, you know, at the early onset. And when you look at this CAT scan, you don't see much. Maybe, you know, there is a little bit of changes here at the lung bases. If you look at on the right panel, it's this kind of haziness you see. That's what we call very early ground glass opacities of very early disease. But, you know, actually, I didn't see the patient here at the onset. These were CAT scan that was brought to me when we start to see the patient. We saw the patient here. The patient had the disease for 10 years. And by the time we saw the patient, the lungs were severely damaged. Started out as a minor problem, minimal. Patient was lost to follow-up. Nobody checked on the patient. And then after 10 years, that's what we deal with. You know, and you can see that, you know, this is a representative tissue slides. This is a normal lung on the upper left, on the upper right here. This is a normal lung. You see there is a very thin web of lung with a lot of nice open air spaces, the air flows smoothly and the exchange of oxygen happen with no problem. And look on the bottom right, that's the damaged lung from scleroderma. All the wall of the air spaces become thick, and this pink thing is scar tissue. Obviously here the oxygen doesn't flow and exchange nicely. So that's why follow-up is key. If you come to our clinic, very likely you're going to have a baseline CAT scan early on, and every year, my patient know, every year pulmonary function test. We do the test where you blow into the tube to measure how much you're able to breathe air in and out, and how good is the exchange of oxygen. Sometimes it seems too much, but that's the reason we do it. We don't want to get surprises that the disease start, we don't know it underneath. Early on, you may not have symptoms, and then fast forward several years, then we realize there is damage, and that damage is irreversible. So this is critically important. Now, not all the scleroderma lung disease is bad. So this is a large cohort from Pittsburgh, and you can see that this is a survival curve. So that means how many patients survive over time. So over 10 years, if you have mild disease, that early on, and it doesn't really change, as measured by the lung volumes. Overall, more than 90% survival more than 10 years, no problem. But if you have advanced, or if there is evidence that the disease is progressing, this is the group of patients where their lung function went below 50%. Obviously, at 10 years, the mortality goes down to 50%. So it's really important that we diagnose and treat progressive lung disease early, precisely to stop, the progression and also improve the long-term outcome. So what treatment do we have for lung disease? As I mentioned, the number one, the most common, the most important organ manifestation that determine long-term survival. So the treatment for lung disease, most of you are familiar with mycophenolate, also called CellCept. That's the brand name. I put it just so you recognize it. That's accepted by experts as still the first line agent. Most of you are familiar with it. The other drug that has been used is cyclophosphamide, but we prefer mycophenolate. And there was a trial, this is the Scleroderma Lung Study 2, that has been done a while ago, which determined that mycophenolate and cyclophosphamide are equally effective in stopping progression of lung disease. These curves are the two drugs, and it shows you that over 24 months, the curve goes slightly up and then stabilize. So you don't lose function, this stabilizes, but they are equally effective. But mycophenolate is much better tolerated. Cyclophosphamide is really a more aggressive treatment with a lot of side effects. So the practice is really to use CellCept as a first-line agent. And you can see that not only the function get better, but even radiographically, this was before the CellCept and after a certain period of treatment, you see that the lungs clear up. Still there is damage, but it's better than it was when the disease was during the acute progressing phase. And so I think it's important that we know that. However, 30 to 40% of patients don't respond to mycophenolate. So it's not the solution. We tried it, and some patients do get significant benefit with mycophenolate, CellCept alone, but there is a substantial subset that does not respond. And so that prompt investigator companies to try to find better treatments. Keep in mind also that mycophenolate is a non-selective immunosuppressive drug, meaning that it broadly lower immune system, is not a laser tag type of treatment. But we are fortunate over the past couple of years, we have more targeted therapy that has been approved and that showed benefit for scleroderma patients, and specifically nintedanib, also known as OFAV, and tocilizumab, also known as Actemra. And so let's talk about these two, which are the new kid on the block, the new tools that we have in our repertoire. So the nintedanib, OFAV, was studied in the SENSIC trial, where a large number of patients were enrolled, and they were comparing use of nintedanib to placebo. Placebo means sham treatment, no treatment. In reality, 50% of the patients enrolled in this trial were allowed to be on CellCept as a background. So it wasn't a full kind of washout and placebo. But what was interesting, they look at 52 weeks. Look at this curve. This curve are lung function. So if they go down, means that you're losing lung function. And you can see the difference between the nintedanib treated group and the placebo treated group, where the placebo went down deeper. So it's steeper and they lost more lung function. In other words, nintedanib slowed down the progression, didn't stop, but slowed down the progression of lung disease. So this led to being approved by the FDA, and the practice is to use them in combination, to use OFAV in combination with CellCept, either as a step-up therapy or in some cases up front, particularly if we know that there is more extensive disease or more progressive. We're motivated to use that in combination up front. But that's a decision that has to be pondered based on the type of presentation. It's not yet recommended as a single agent. I've seen patients come into our clinic that have been started only on nintedanib or OFAV. The data the data that we have so far do not support use that as a lone therapy. I think the combination is where you have the best out of it. But I think it's exciting that we have another tool, and we know that this medication, OFAV, also target the scar tissue, the cells who make scar tissue, decreasing production of collagen. So exciting to have this. One note is about side effects. During the clinical trials, patients who were taking nintedanib, OFAV, 75% developed diarrhea. So that's a common side effect that we expect most of the patient will experience. What's important though, if you look on the bottom here, only a minority, only 16% of patients stopped the trial due to side effect. What that means is that it was not a symptoms that was severe to the point that you had to stop the drug. So we have a way to adjust it. We decrease the dose, or you control the diarrhea. In the vast majority of cases, it becomes tolerated. So that's important, so you're not scared that 75% of people would not be able to be on the treatment because of side effect. The other medication, the other new tools that we have is called tocilizumab or Actemra. It's an injection. So nintedanib is a pill you take every day. Tocilizumab, Actemra, is an injection, a subcutaneous injection they do every week. And here, it was compared to placebo again. In this case, patients were not taking any other medication. And the part of the study, they look at the lung function, again, comparing baseline lung function to after 48 weeks, a year, show a dramatic effect on the patient that had interstitial lung disease. And they are represented on this graph. You see on the red line is flat. It doesn't, so remember, this is lung function. So that means over a year, patients who were taking the tocilizumab did not lose any lung function, as opposed to patients who were taking no drug. In this case, really, there was no background therapy. They lost function here. And that was a very striking difference that, again, convinced the FDA that this was a good drug for scleroderma ILD. However, you have to remember one important part. This trial was designed to treat early active skin disease. So what was very unique about this trial, it was not designed for people with lung disease. They said, well, let's treat skin disease and we will welcome patients who have lung disease. And it turns out that it didn't do much for the skin, but it was beneficial for the patient who had lung disease to the point that the FDA approved it. However, this creates, though, the question of, is this applicable to every patient? Because they were targeting skin disease, they wanted patients that had very short disease duration, less than 3 years from disease onset. They wanted to have patients with active progressive skin disease, that early phase where the skin really gets worse rapidly. And they wanted patients with high inflammatory markers. There was like a big load of inflammation. So really, I think this is not applicable to every patient. And that's, again, another discussion that you need to have with your doctor, whether you are the right candidate to receive this type of therapy. On the other side, though, tocilizumab, this is a medication that's been already approved for rheumatoid arthritis, inflammatory joint disease, for a long time. So in some way, it can be also interesting on the subset of scleroderma patients. Some patients do have also rheumatoid arthritis overlapped to scleroderma. So maybe this is an option to use one drug to take care of two problems. So it's a little complex, but I think it's exciting, really exciting, that we have now 2 new drugs that we can add to our repertoire beyond CellCept, knowing that even CellCept, who is considered the best drug that we have, a third of patients would not respond to that. And so what else can we offer to our patients when it comes to lung disease? And so we should talk about transplant, two types of transplant. One is the one I think you're all excited about to hear about, is the autologous stem cell transplantation. And I want to make some clarification about this. And the other is actually the actual lung transplant, which I still think people don't know much about and is important. So is stem cell therapy a cure for scleroderma? Is this the holy grail to take care of scleroderma? And the answer is no. But there are some interesting aspects about it. So first of all, what is a stem cell? Because I got asked this all the time in clinic. Can I get the stem cell, or is there a stem cell that we can get? So the stem cells is a cell that can replicate itself indefinitely, has this kind of power to really continue to replicate. It never dies, and also can differentiate in any tissue, can sort of take the direction to become different type of tissues. And so the hierarchy, so there are what we call the embryonic stem cells. You heard the term probably. These are cells that can, they don't have specificity. They are the primordial cells. They are the one that you have into the embryos that turn into a fetus, into a baby, and they are the one that generate all the different tissues in the forming baby. But then you have the adult stem cells. They don't have the same power of the embryonic stem cells, but they still, within some commitment into different tissues and organs, they can replicate themselves. And these are the ones that also we look at can they regenerate, damaged tissues. Now, when it comes to scleroderma, the stem cells that we talk about are the one that generated different cells of the blood. These are called hematopoietic stem cells. And what they allow us is to do what we call the bone marrow transplant. So the principle, how we use them, is very simple. So the step one is the patient own hematopoietic stem cells. So these cells that can turn into blood cells are collected from the circulation and frozen. Then we give to the scleroderma patients high dose chemotherapy, cyclophosphamide, and in some cases, total body irradiation. These are chemotherapy like protocols to kill all the cells that we think have disease or kill the bad immune system. Obviously, there are innocent bystander that in this very aggressive therapy will be damaged. And then once everything is wiped out, we re-inject these stem cells to allow the immune system to come back. Again, the principle is not to regenerate tissues or anything, it's just to allow the bone marrow, the blood cells to be repopulated. And so there's been 3 trials that now are well known and have been published. And the general principle of this trial is to get patients with severe enough disease that they need aggressive treatment, but trying to protect those who are too sick, and then to randomize them to receive either the high dose chemotherapy, cyclophosphamide, followed by the stem cell transplant, or just the low dose cyclophosphamide on the right every month for up to a year. And basically, what did we learn about the stem cell? What do we know now is that, number one, it's an effective treatment. So there is rapid skin improvement, stabilization of lung function. So the lung function sort of level off in a nice way. When we ask the patient if they feel better, the measurement that we use, the patient-reported survey, tell us that the quality of life is better. And potentially, on the long run, there is improved survival. However, there is a big issue with treatment-related mortality. That was high. 3 to 10% died from complication. And I show you this on this. This is an example for one of the trial. What you can see here, these are survival curve, is that on the first year, right after receiving the treatment, there is a steep decline of survival in the patient receiving the stem cells. And this is like the patients in the transplant group were more likely to die, and this was due to the medications. So even if on the long run there was some signal that a survival perhaps was better, we were losing a sizable number of patients early on because of the toxicity of the treatment. So this gives us the point that we need to be very careful and we need to select the right patients. Very important because 3 to 10%, if I say you have 3 to 10% chances of dying because of the medication, not because of the disease, that will certainly impact the decision. We also learned that there is a third of the patient who have durable remission, but relapses occur. So it's not a cure, it's not a holy grail. 2/3 of patients, the disease will come back, and in some cases, very aggressive. So we need to look for better way to treat. And we don't have long-term follow-up data, meaning one concern we have is secondary cancer, because this is a lot of chemotherapy. So we are still awaiting this long-term survey. So stay tuned, because it's not done. Obviously, we are not done looking into this type of approach. There are some new, there will be new trials and new type of way of using stem cell, and including using stem cell from other patient that is not yourself, others that are individual, healthy individual that is not yourself. This is called allogeneic as opposed to autologous. It's a little more complicated, but it's a frontier that we will move forward to see whether we can truly get something that wipe out the bad cells and they don't come back. Now, to conclude, the lung transplant, the surgery, and I think this is important, because you know, my experience has been the surgeons don't want to transplant scleroderma patients. And remember, there is a situation where nothing is working anymore. It's you know, end-stage lung disease, and so lung transplant is a life-saving procedure. It's a last resort, but it can really be saving life. The surgeons are reluctant because scleroderma patients are sick, and particularly they are concerned about acid reflux and aspiration into newly transplanted lung. But the data, we reviewed that when I was at UCSF, showed that the two lines are overlap in terms of survival, meaning that patients with scleroderma ILD do the same as patients that were transplanted for lung disease due to other causes. And so we really think that in the right context, you know, this and with the right team of people, we can really make a difference. Now, what's important is how do we decide? How do they decide who receives the lungs first? This is an important switch that happened before. It was just basically just a regular wait list. The sooner you sign up, the sooner your turn will come. But now it's changed. Now we have criteria based on the comprehensive assessment that we do to give a score. So basically now who needs it and benefit from it the most will receive it first, and which is exciting, because then we can really strategize. You don't need to, you can do all the workup and be ready when the time comes. And it's a long process. I won't get into detail this time, but I want to emphasize this, that you know, there is an ideal timing for transplantation and an ideal timing for evaluation. Obviously, the transplantation will happen when, you know, the disease and the lungs in particular are basically not functioning anymore. Oxygen is oftentimes already on board. You don't want to wait until the patient is too sick. Obviously, they may not survive the transplant, but you know, there is a window where transplant is indicated. However, the evaluation, that's a different story. And so if you hear from us saying, hey, let's refer you to the lung transplant team, it's not that you may be near the need for the transplant, but because the process is very long, it's better to know early if you meet all the criteria, what's the situation. So I think this is a valuable opportunity, and I'm excited because at Cedars-Sinai, over the past 2 years, they developed an amazing transplant program, and they brought a skilled surgeon, the one on the back, Dr. Catarino from the UK, from Cambridge, UK. He is a pioneer on doing novel technique for transplant, and Dr. Rampolla, Dr. Mena, they're really excellent transplant pulmonologists, and we are excited to work with them, because my experience when I was at UCSF, I've seen a lot of my patients surviving a end-stage lung disease and having a new shot at life. And this is what I want to conclude with. Lung transplant can be a life-saving treatment. I have inspiring stories. One in particular, Lovette, is a dear patient of mine that followed me at Hopkins, UCSF, and now here. This was us in 2015. We were at UCSF. You can see her with the oxygen and the oxygen tank. At that time, there was no response to treatment. We started to talk about transplant, and then it came in 2019. So it took a while, 4 years. And this is her. This is the first time she stood up 2 days after the transplant. You can see all the tubes, and it's not a minor procedure. So don't get me wrong. I'm not telling you this is like going to a dermatologist for a biopsy. So this is a major thing, but this is her, already, with her determination, very inspiring determination to go back to function. And this year she ran the Peachtree Road Race in Atlanta, where she's from. And the commitment is that next year we're going to run it together. We want to, build a team for scleroderma, showcasing that even people that at some point felt they were at the end of the rope do have hope, do have possibilities to really go back and live their lives. Not an easy path, but people like Lovette really inspire me to do the work I do every day. And again, we don't want to get here for everybody, don't get me wrong, but we know that till the end, we can really provide care and make a difference. And since we're almost Christmas, I conclude with this, what's your wish for Christmas? And Peanuts always is able to, in few words, tell us something that is important for us all, and we always think about. So thank you for your attention. And now, hopefully, I didn't take all the time for question.
No, you did great. That was a wonderful, wonderful presentation, Dr. Boiin, and it really gave everybody a lot of insight over the treatments that are here today, the treatments that are coming, and a great insight into some of the more aggressive ones, but how you're planning on making sure that you're putting a priority to the right patients at the right time. So I want to thank you for such a wonderful, detailed presentation. And I got a couple questions. A couple of them started early. And the first one was, do you offer telehealth?
Yeah, so we became experienced with telehealth during the pandemic, of course. And at that time, we could do it countrywide. Now the rules changed back to normal, which means that we can do telehealth only within California. So we do see patients in video visits in telehealth. But I would say that in general, this is good for patients who are stable, that have to travel. So we definitely alternate in-person visit with video visits. For a new evaluation, I would discourage doing telehealth because, as I hope I convey you the message, this is a complex disease. There are a lot of nuances. And for us to be able to talk to the patient, examine the patient is critical. But definitely, we definitely are open and motivated on also leveraging, telehealth as a way to be in touch with our patient and working together. So it's a partnership that can have many different ways to be implemented.
That's wonderful. And I would like to add on that, while telehealth does make it easier, especially for some that can't get there quickly, it is important that you can touch the skin, look at the different things on their body, as well as listen to their lungs. And telehealth, while it's helpful, doesn't meet those criteria. And for a scleroderma specialist, you make sure that that's an important component of seeing your patients. So thank you. Do you provide seminars for CEUs for RNs?
So, as part of our education kind of commitment, we will hope to develop programs that are only also addressed to nursing and at the moment we don't have established that yet, but we will do CME courses. And irrespective, if anybody feel they want to learn more, they have questions, we can definitely be available to talk or to provide tools. And so we're here also for if needed, a one-on-one sort of discussion. So feel free and encouraged to reach out. We will help if you can.
Thank you. And I wanted to add that the Scleroderma Foundation of California is working on, in the very near future, CEU programs with doctors such as yourself. And that is something that we're hoping to do very soon.
Yeah.
Another question. Do you have any resources to assist patients emotionally? Do you refer them to support groups?
Yeah, so absolutely. We try to be connected with many. In fact, I was going through the list of the attendees. I met many of you also, not in clinic, but in support groups or meetings. So we definitely have some connections and we can help connecting and facilitating relationship with support groups. On the other side, and we are connected with the Scleroderma Foundation and the partnership, particularly with the Scleroderma Foundation of California, is critical for us now that we are present in California. I want to emphasize that in the pipeline, again, we're building, there will be some dedicated effort to develop emotional support or psychology support for our patients. We have to frame it properly, but I think it's an important part of what we do. Is not only the biology of the disease, it's also the impact that the disease has on patients and the caregivers, the loved ones. So this is an area we will get back to you again. We had to sort of think about more, but it's very important to us.
Thank you. Do you work with any primary care physicians or dentists to help educate them about or specific issues and needs?
I always tell my patients that we are not here to cut anybody out. We are here to actually create teams of people that can deliver the best care. So for me, the connection with the primary care physician is critical. And I always encourage them to call me if they have any questions. Similarly, I don't think dentists, there are expert on scleroderma dentists, but I have to tell you, I speak very frequently with dentists, general dentists, but particularly like periodontists or orthodontists when there are procedures that need to be done. The challenges are the oral aperture may be smaller, or there are a lot of gum recession. The question is, if I do an implant, will it stick? So I do have, regular interaction with my patients, dental professionals, to really give them feedback and advice on what can or cannot be done, or how to do it, or what's the timing of doing certain procedure.
Thank you. I appreciate you actually mentioning that. And I guess that gives everybody great hope that if you're seeing a dentist that might not really understand, because they're far and few between, that you're open to talking to their dentist and helping them educate them a little bit on this. We also have some talks from a couple dentists that could be helpful that you can share with your dental team. He also said to thank you for your dedication and terrific care that you provide. Thank you, Josh. Awesome from Thais. And Patricia, thanks for the transplant information. I had a transplant at UCSF in 2010. Congratulations, Patricia. And thank you. I'm currently trying to be cleared for the lung transplant surgery. You give me hope, from Lori. Thank you, Lori. Dahlia, my blood work showed positive ANA for limited scleroderma. Only symptom is Raynaud's, and was told it's not full-blown scleroderma until a second skin condition appears, and reluctant to do a CT scan. How can I convince my rheumatologist that it's not true based on what was discussed today?
Yeah, so it's a switch that we're trying to drive in the concept that scleroderma, if you have only limited disease, is not a big deal. That's not true, and I totally agree with you. We take it seriously. We look at every single aspect, and every patient get an echocardiogram, pulmonary function test. Most of the people will have a baseline CT scan, and we examine them very carefully, knowing what we're looking for, hints that there are internal organ involvements. But I totally support the notion that the fact that you have limited disease doesn't mean that you're not going to have, that is impossible you have internal complication. We have to look for that, or make sure that we are in control and follow over time. So absolutely, I hope your doctor will be willing to do all the full workup and have this open mindset, because it's your life, and it's important that the due diligence is done. So absolutely in agreement with you.
Thank you. If I already see a Cedars-Sinai rheumatologist, would I need to switch doctors to be seen by the Institute?
Well, we obviously, I have an expertise, a disease-based expertise. So if I have patients who transfer care to us, or I have patients who are followed by other rheumatologists who periodically sees us, but they stay with their own rheumatologist, and that's totally acceptable. Again, we are here to help, and we work with other rheumatologists as well. So I have many patients who, sees their regular rheumatologist more often, and they come see us twice a year, where we give them and the rheumatologist they normally see feedback on what we recommend or what we see is going on, and provide feedback. So either solution is fine, either full transfer or even partnership. Don't need to leave the rheumatologist you may be attached to and would like to continue to see. Totally feasible, no problem, no barrier for that.
Thank you. Would Cedars-Sinai consider partnership on research with allied health professionals?
I don't know what that means, in the sense it depends what research we're talking about, but we definitely are open to many different type of research. I hope I gave you the spectrum of what we do, that range from just a cohort development to patient-facing activities, quality of care, and then ranging to more advanced basic science research that is done on the bench. So we are open to any research that is meaningful and scientifically valuable to our patients. So absolutely open to ideas, open to collaborations.
Thank you so much. And she also mentioned she works with occupational therapy and lives with scleroderma herself and really wants to bring something to the forefront. So Penny, I'm sure that this is something that could be discussed.
Yeah, absolutely.
Thank you. How to qualify for research?
The only qualification needed is if you have confirmed diagnosis of scleroderma. So that's a minimum requisition to be part of the scleroderma cohort. And then obviously, if it gets into more specific protocols, there may be some studies that are more pertinent to people, for example, with lung disease, or clinical trials have enrollment criteria that need to be respected. But the basic participation of research is to be part of this large cohort we're building to really follow patient over time. And for that, the only requisite, enrollment criteria is that you have that we confirm that you have scleroderma.
Thank you. Melissa, you asked about emailing questions. I don't think I can keep up with trying to look at emails while we're doing the Q&A. I'm not sure if you're asking to do additional, but remember, we also have 30 minutes at the end to answer questions on our entire panel, and I hope we'll be able to answer everybody's questions. She also asked if there is a doctor at UCSF that specializes in scleroderma that you would recommend.
Yeah, so you can look at their website. I think that I'm not sure who is there now, meaning there was Dr. Sarah French and Dr. Andy Gross. I'm sure Dr. Sarah French is still seeing patients, and she worked with me when I was at UCSF. So I definitely know that they have still doctors who have sort of focus on scleroderma. I don't know the availability, but definitely they have a clinic that dedicates to scleroderma.
Thank you. I don't know what this means. What is the percentage of AA women with scleroderma?
Yeah, so that depends on which part of the United States you are. When I was at Johns Hopkins, that was higher than where I am now, because Baltimore had a higher prevalence of scleroderma patients that were African American. But in general, it's between 15 to 20% of our cohorts. What is clear is that African American patients have disease starting earlier, higher burden, so more severe kind of organ involvement and higher mortality. And that's why we decided with the NIH to study specifically African American scleroderma patients to understand, is there a genetic predisposition, or are there features that we can identify that explain why the disease is more aggressive and more burdensome in this population. There are other ethnic groups, that also some Native American groups and some Asian subset of population that have more aggressive disease. So it is really possible that there is a variation in different kind of patient populations, and studying you need high numbers to do these studies. You can't do it on a small group. That's why we partner up with 20 more and plus academic institutions.
Thank you. We're running out of time. We will continue with these questions at the open panel discussion at the end. But right for now, we need to end the Q&A and start with the next speaker. So Dr. Boiin, thank you for this really great presentation, and we'll pick up where we left off at the end. So thank you very much.
Thank you so much. Thank you all.
Okay, I'm going to unpin you. And Dr. Bottini, we're going to spotlight you. One moment, everybody. And so we're going to be hearing from Dr. Bottini, and he's going to be talking on research updates in scleroderma. Dr. Bottini is the founding director of the Keio Autoimmunity Institute and a staff physician in the Division of Rheumatology and Scleroderma Center at Cedars-Sinai Medical Center. Previously, Dr. Bottini held appointments at the University of Southern California and the La Jolla Institute for Immunology, and he was a professor with tenure and the rheumatology section chief at the University of California, San Diego, until his recent move to Cedars-Sinai. Dr. Bottini's laboratory has been federally funded for 15 years. to study local mechanisms of inflammation in rheumatoid arthritis and scleroderma and identify new drug targets for these diseases. He is an expert in a family of enzymes called phosphatases that regulate biochemical signaling inside various types of cells. In collaboration with Dr. Boiin, his laboratory has discovered a phosphatase whose levels are elevated in scleroderma and that promotes various mechanisms of fibrosis. In his free time, Dr. Bottini enjoys family outings with his wife and their 4 daughters. Please join me in welcoming Dr. Bottini.
Thank you, Tina. And I want to thank, can you see my screen?
Yes, we can see your screen. Thank you.
So I want to thank you and Andrew for the invitation, and I thank the foundation. I also want to thank the patients and their families for attending and for inspiring our excellence, both in the clinic and the science. And so this is the outline of my talk. I will give you an introduction to the Cow Autoimmunity Institute that I have the honor to be the founding director of. I'm going to give you an overview of the key problems that will be focused on at the Cow Autoimmunity Institute. A few key concepts for fibrosis reversal, hopefully we're going to be achieving in the future. And some examples of fibrosis reversal projects, list what we're aiming for at the Cow Autoimmunity Institute. So first of all, I mean, as I mentioned, I have the honor to be the founding director of the Cow Autoimmunity Institute. This is an institute which was created through a transformational gift from the Cow family. It provides the laboratory structure and expertise that enables the research mission of the Scleroderma program directed by Dr. Boiin that he described at Cedars-Sinai. And this is actually our goal, stated briefly, that through science, we want to drive key changes in the way scleroderma patients are treated in the clinic. So briefly stated, we want to make an impact on scleroderma for the patients. So the Institute has state-of-the-art biology and immunology laboratories. I'll show you like this on the left side, like the main lab, and on the right side where actually we handle cells. So this is a sterile environment that are very in physical proximity to the scleroderma clinic. And so the goal of the Institute is really to do science that helps the patient, and the science that helps the patient begins with the patients. So this is a little outline of, the type of science that we want to do at the Cow Autoimmunity Institute. So samples donated by the patients who are followed over time in the scleroderma clinic will be studied in a specialized KI facility, which we are creating. The data that is produced by this KI facility will be analyzed, leveraging the outstanding computational infrastructure of Cedars-Sinai. Cedars-Sinai is investing a lot in computational medicine and has just opened a new whole department of computational medicine. Based on the data and the outcome of this, we will perform experiments to just make sure that the targets that we have identified are the good one. This experiment will be done in cells in animal model, also at the KI. And then once we have identified what to target, we'll connect with industry to develop new personalized medication and diagnostic assays. So our goal is really to make discoveries that will enable industry to bring new medications to the patients. So when I got the offer to join the Cedars-Sinai and direct this exciting new institute, of course I was excited. And for a doctor, it's kind of hard to say no when Cedars-Sinai extends an offer to you because of the clinical excellence and research excellence. And the idea of the institute was extremely exciting. However, I was at another excellent place, the University of California, San Diego. So I actually had to assess what was the probability that would actually we make an impact. And I think there are some key factors that that poise us to make an impact. And one of them is that I have a proven science partnership with the director of the division and of the Scleroderma program that KI it's actually destined to enable. So we started working together in 2016 when Francesco was still at University of California in San Francisco. And we got first pilot funding from the NIH as here. We published the first paper in the top journal. Then we got larger funding from the NIH. Then he moved to Cedars-Sinai. Then we published a second paper in the top journal. And then I moved to Cedars-Sinai. So we have a proven successful scientific collaboration. We share passion for helping scleroderma patients. Our scientific expertise is complementary. It's covered the same range, but for example, Francesco Boin is an expert also in creating scleroderma cohorts, while I'm actually more of an expert in molecular science, in addition to seeing scleroderma patients. And we will actually work together in scleroderma clinic. In addition to that, there are, I would say, bigger factors that increase the likelihood we'll be successful in the scleroderma, and the KAI can really contribute to the success of the scleroderma program. Because on the scleroderma program, there is a convergence of multiple very excellent infrastructures. And so you can see here that the KAI will provide laboratory and specimen handling infrastructure. The division provides an excellent scleroderma clinic and all the regulatory infrastructure. You heard from Marianne about the translational research unit, and we can leverage the vast technology and computational infrastructure of Cedars-Sinai. So now I'm going to give you an overview of like three, I would say, key problems that we would like to address at KAI. So the first key problem is that disease, as Francesco Boin mentioned in his presentation, disease mechanism is complex in scleroderma, and I would actually argue that it's more complex than other autoimmune disease. The reason is that this is what we present, what we teach fellows as the triad of scleroderma. So there is inflammation and autoimmunity. But as Francesco Boin mentioned, there's also vascular injury, which is exemplified by Raynaud phenomenon. So there is a problem with the blood vessel. And at the end, this converges into fibrosis, which is the scarring, which is a major problem for the patient. We don't know exactly what is going on in the affected tissues and in each patient. And as Francesco Boin mentioned, the disease is highly variable between patients. So we currently use medications that are not patient-tailored and thus are not curative. So our objective at KAI is to understand the mechanism of disease at the tissue level, looking at what we call in science the microenvironment, and in each patient through spatial biology. So now, what is spatial biology? So a simple explanation of spatial biology is that it is similar to human tissues are similar to neighborhoods. And if you live in Los Angeles, you have an appreciation of how pleasantly different are all the neighborhoods of Los Angeles. And today we cannot really work in a civilized society without really deeply caring about diversity. And it's the same pretty much for science. So we cannot really cure a disease that affects specific tissues without caring about the specific diversity from tissue to tissue. So what spatial biology does, and in this is an image, this is a microscopy image that shows you in a tissue different cells that are stained in different ways and how they're really close to each other. And you can see they touch each other and they interact with each other. And this situation is different from tissue to tissue. So what spatial biology does is studies the relationship between different cell types in the context of their natural tissues and how the relationship is altered in disease. It is a very modern field, and it requires complex and expensive technology and high computational power. Both of them, we will have them at KAI. So the second problem that we want to focus on is that, as Francesco Boin mentioned, not only patients, they are different from each other in the way the disease manifests itself, but also in the way the disease progresses and the pace at which the disease progresses. We currently don't have a lab test that allows us to predict who's more likely to progress quickly, and then we would recommend a more aggressive treatment. And the example I always make is that genomics, which is the study of the human genome and the knowledge of the human genome, has really revolutionized the way we treat cancer. Nowadays, if a patient is diagnosed with cancer, the patient is very likely to give a little sample of the cancer. The cancer gets analyzed for mutations in the DNA. And then the therapy is really tailored based on the mutation. And that has been a real revolution in the last 20 years, which has led to patient-tailored therapies, which are more effective. Now, the similar power of genomics has not been applied to the development of tests that could actually allow us to personalize therapy, even the current therapies, to the patients. And so our objective is to apply state-of-the-art genomic studies to blood specimens. Because the peripheral blood is always the best place to go for a marker that would predict course of disease on patients that are followed in our specialized clinic to find tests that predict progression of disease. And the third problem, which I'm sure is very dear to a lot of you and your families, is that a lot of the patients, they already present to the specialist with scarring, with fibrosis. That's because it's a very difficult disease to diagnose, and so diagnosis is often delayed. And as Francesco Boin said, there is a lot of emphasis on early diagnosis. However, early intervention is still difficult because we don't see those patients often in an early stage. So that leads to the fact that current therapies are currently focused on slowing down the progression of scarring rather than restoring normal tissue. So we would like to strongly focus on fibrosis reversal, which, it's arguably not easy to accomplish because a lot of the tissues, once they're scarred, it's, as Francesco Boin said, it tends to be an irreversible process. And so here, I want to move to the third part, which is a little bit, a few new concepts about fibrosis and that makes us hopeful about reversal. And so as an initial primer, I'm sure all of you know that when we talked about fibrosis, we mean really scarring. And what scarring is an accumulation of material that it's in between cells, which we call intercellular matrix. And a lot of it is collagen. And so here you can see on the left side, a CT scan that shows, a damaged lung due to scarring. While on the right side, if you look on the microscope of this tissue, you can see those are the little walls in the lung, and air is right here in the empty spaces. And the walls are supposed to be very thin so that the oxygen can go from those empty spaces into the blood vessels that run in the wall of the lung. And you can see that when there is fibrosis or scarring, there is an increased amount of material in between cells, mainly collagen, that then leads to difficulties for the oxygen to go from the air to the blood vessel. And that's really the problem with the scarring of the lungs. And so scarring destroys skin structures such as hair and sweat glands, also reduce the ability of lung to exchange gases, and also destroys organ function, including the GI, as we're going to hear, I'm sure, in the next presentation. And so the fibroblast is a cell which is really essential for the scarring process, that, in normal condition, we're very lucky to have fibroblasts because, for example, they are in charge of healing our wounds. And so they normally maintain the structural integrity of our tissues and regulates the composition of this matrix that is in between cells that deposit collagen. And then what happens is, if there is, in a normal process of scarring, the fibroblast, it's there usually in a quiescent state. It's not doing much, but when the scarring needs to begin, like for example, during normal wound healing, there is this process that we call fibroblast activation, which leads the fibroblast to become what we call myofibroblast, which mainly is a cell that is able to contract and deposit this matrix in between the cells. And this initial activation, it depends on several stimuli, including the fact that there is contact with immune cells. So in inflammation, our white blood cells, they go into the tissue and they actually direct the cells that are in the tissue, including fibroblasts, to actually give them a sort of an alarm stimulus saying that something needs to be done to correct the problem. And so the contact with these immune cells is important to activate them, as well as the immune cells will release factors, molecules that will activate the fibroblasts. So the fibroblasts get activated. And then, unfortunately, what happens in scleroderma, once the scarring has begun, there is a little bit of a vicious cycle, because those cells that normally in a wound healing process, they would actually then deactivate themselves. They tend to remain activated. That's because the Scleroderma fibroblast is more sensitive to the increased amount of matrix. So unfortunately, it will deposit matrix and then it'll get stimulated itself by this increased deposit matrix. Second, it tends to get genetically modified with a prolonged inflammation. And then the other very important point, which is becoming clear nowadays, is that the very stretching of the skin, so the increased stiffness of the skin that is due to scarring, send to the fibroblast the wrong signal that they should continue to scar. So the good news is that, you know, now we Scleroderma patients tend to continue to have these activated fibroblasts in the skin and the organs, which, as I mentioned, they tend to maintain them. This activation tends to be maintained through a vicious cycle. But the good news is that fibroblasts can be either deactivated or eliminated. And so deactivation or death of activated fibroblasts is possible. And when that happens, the tissue undergoes a rearrangement that, at least theoretically, could reverse the scarring. So we call this rearrangement remodeling. And so you can see in this process, the fibroblast was quiescent, it gets activated, it becomes what we call a myofibroblast, which is it's a cell that can move more, it can deposit more of this collagen matrix, so actually it mediates the scarring. But then it's also possible that the fibroblast deactivate or it dies. Apoptosis is a technical term that we use to indicate cell death. And then when this happens, there is matrix remodeling. So here it brings me to come up like 2-3 key concepts, I think, that are interesting for anybody like you and I are always interested in reversal. And one of these is what we call mechanotransduction, which is a complex term to say that certain mechanical stimuli can then be transferred inside the cells and generate signals that activate the cells. And so I think in this image that I took from Twitter, I think it exemplifies the fact that this is a cell that, you know, normally it's in a soft skin that is not scarred and is kind of like resting. And then what happens with the scarring, the skin becomes stiffer, kind of harder. The cell feels the stiffness as sort of a pressure around itself and it gets kind of awakened. And then when the stiffness becomes harder, the cell decides to respond to it. And then normally, basically with the response of a cell during the normal process of scarring is to actually start the process which I call remodeling, which means to progressively reduce the scar. But unfortunately, in the Scleroderma fibroblast, the mechanotransduction is abnormal, and they signal to activated fibroblasts that they need to keep going. They need to continue the scarring process. Another interesting area is actually that I want to mention this study because that gives a really hope that the fibrosis can be reversed, is, for example, application of technology that has been used for accomplishing COVID-19 vaccination. So you all are familiar with what we call mRNA vaccines. These mRNA vaccines, they drive the expression of specific proteins from COVID in cells that then allow the immune system to see the protein and develop a response that protects us. So using the same technology, this group at the University of Pennsylvania this year published this really high-profile paper showing that, say, this is a particle here similar to a COVID vaccine. This is taken from their paper. It carries mRNA. This particle gets injected. It was injected in mice for now. And then it directed an immune cell called T cell, pretty much like the COVID vaccine directs other cells to express a COVID protein. This actually expresses a protein that allows these cells to attack the activated fibroblast based on the expression of a specific target. So this is activated fibroblast in the fibrotic tissue. It expresses a specific target. Normally, immune cells won't attack the specific target. By using a technology similar to the COVID vaccine, you can actually instruct them to do that. And this actually led, very interestingly, to reversal of fibrosis in mice, which means mice had already scarring, and this sort of like experimental vaccine was injected in mice, and that scarring actually was reduced afterward. So this gives us hope that reversal can be accomplished. And you saw in the previous slide that it's really important that to have those targets that those immune cells would attack. And so there is a lot of interest in actually understanding what those fibroblasts express on their surface and characterize molecules that are expressed by different subset of fibroblasts. So there's a lot of complexity there. And this type of research is leading to another interesting observation that there might be actually other subset of fibroblasts that might be protective against scarring. And so another potential option would be to, for example, boost those fibroblasts instead or in addition to decrease the activation of fibroblasts. And so in this another seminal paper that was published in a top journal by a group in Israel this year, they actually showed that there is good fibroblasts that express this molecule called LGR5. And during the course of fibrosis, which you represented in the skin, by, this is a scheme of the skin, and this is the epidermis and dermis, and you can see there are fibroblasts here. Those are the good fibroblasts, and there are few fibers of collagen. Fibrosis, these are healthy scleroderma, healthy skin fibroblasts, and then this is limited, and this is diffuse systemic sclerosis. And you can see that the more collagen fibers were deposited in the skin, the less of those good fibroblasts were present there. So I'm going to spend the last few slides kind of like mentioning a few points about the project that has been ongoing in collaboration with me and Francesco Boin, that actually now we have a lot of infrastructure at KI to carry on at Cedars-Sinai. And as Tina mentioned, my laboratory specializes in a family of enzyme of molecule called phosphatases. So in collaboration with Francesco Boin, we actually studied those phosphatases in skin samples from scleroderma patients. And I want to highlight how those small skin samples that the patients donate in the clinic they have really been the base for pretty much most of the discoveries that I described during my talk today, including going back to the previous slide. This was a study done on several skin samples from an Israel scleroderma clinic, and as well as this one that was done for several skin samples from multiple scleroderma clinics. And so here I want to show you like an example of the data that we published together. And so here you can see that we measured the expression of this phosphatase in the scleroderma skin versus healthy skin, and you can see how, in many patients is much increased. Here's a microscopy image where in green you can actually, those are cells in the skin, little skin sample from the patients. You can see group of cells. The blue is the nucleus of the cells, and in green we see the expression of this protein, and you can see the healthy skin doesn't have it at all. You can see patients with scleroderma, with diffuse scleroderma in the early stage, they have a lot of this protein. Diffuse in a late stage, they have a lot of this protein, and in the limited, there is also more expression than the healthy skin. And so we actually performed experiments over several years to understand what this protein does in the skin and lung of scleroderma patients. And we made a couple of discoveries. So we discovered that this protein associates with an important driver of fibrosis called SRC, actually the acronym SRC. And when this protein called PTP4A1 and SRC are together in a complex, SRC is triggered to drive fibrosis. And I thought I would show you this image, which also we published together with Dr. Boin. Because it's really, I think he has a very strong visual impact. We have developed a technology that allows us to look at this complex between PTP4A1 and SRC in the tissues. And you can see that wherever you see a magenta dot, there is a complex between PTP4A1 and SRC. And you can see that in healthy skin, you see very little dots and they're very small, while in the fibrotic skin of scleroderma patient, you see a lot of those dots. So it's very noticeable. Next, as I mentioned in the scheme that I mentioned in the previous slides, we really followed that type of thought process. We started from patients' scleroderma samples, and then we made studies to identify potential targets. We have to then do experiments to make sure that this target is good. And experiments are classically done in fibroblasts from the patients, and then the ultimate experiment albeit not perfect, is actually to utilize a mouse model or another animal model of fibrosis. And so what we did is we made mice that lack this protein PTP4A1 in all tissues, and you can actually eliminate the protein at any time of the life of those mice. And this is really important because it's a mimic of what a medication that targets this protein would do. And so we were asking the couple of questions, which is, in this mouse model of fibrosis, elimination of PTP4A1 would be effective, and would we see any evident clinical toxicity? And so we also published this, that we eliminated PTP4A1 after the onset of fibrosis. So we induce disease in mice, and then we actually eliminate the protein. And this actually reduced disease in mice, and we did not see evident clinical toxicity. Of course, this doesn't mean any medication need to undergo a very rigorous toxicology testing that takes, a long time. And it's strongly monitored by the FDA. So this doesn't mean that this won't have any toxicity, but it gives us some hopes. And so you can see here the way that we measure the thickness of the skin of the mice in those mice. And you can see how this is similar to the Scleroderma skin. These little white lobules here, they are fat, and normal skin has a good amount of fat. And in Scleroderma, it is known that once the skin becomes fibrotic, you can see that this fat layer is gone. And after elimination of PTP4A1, we see a thinner fibrotic skin with a reconstitution of the fat layer, which is definitely, makes us think that it's relevant to Scleroderma. And so then we move to the next step, where actually it's increased complexity. And I'm not, I'll just show you that basically at the end, if you look inside cells with a microscope, you can actually see the structures of the cell, like the nucleus, the membrane, and so on. But actually, we're all made of molecules, and molecules are extremely, extremely small, and you need a very big electron microscope to see the molecule, or you need to perform specialized approach, like, for example, crystallography or nuclear magnetic resonance. And so we actually have done some of those approaches, because for us, in order to target this complex with new medications, in order to start even doing that, we need to know how this complex looks like. And so we have done that approach, and we actually have an idea of how the complex looks like. And so you can see here, this light blue is actually the protein that we specialize on, which is PTP4A1, and the pink one is SAR, this molecule that the protein forms a complex with. And the green and blue are the surface, the areas where the two molecules interact with each other, which actually we think we could target for new medications. Of course, this is an early stage, but this is, and this, it's a molecule. I couldn't replicate a sort of rotating molecule here, but it's important to look at this complex from all angles. And so you can see this, from all angles, from all the 4 angles. So each time, you rotate like 90 degrees. So again, as Francesco Boin and Tina mentioned, we already published 2 great papers on this, and now we're going into the next step. We already started the search for molecule that can disrupt this complex between the phosphatase that we work on and this promoter of fibrosis. Once we have early molecules, we will work with chemists. We hope to develop the medication for slowing down and hopefully reversing fibrosis. But mainly, I think I mentioned this project. This is an example of the science that we want to carry out at KI with your help. So it's what basically we call bed to bench and back to the patient. Thank you very much for your attention. And, again, I thank you for attending, and thanks to the foundation. I'm ready to take questions.
Thank you so much for this very informative talk, Dr. Bottini. Guys, I'm going to go into the Q&A, and I'm going to start with the bottom and move my way up, because this is my first time using Q&A, and I don't want to overlap some of the questions from before. If by any chance, guys, I lose a question, you might need to retype it during the open session with the panel. I apologize, but I just wanted to throw that out there. So I'm going to start with some of the, let's see here. I'm not seeing. From what I'm seeing, amazing. Thank you.
Thank you.
Some of these are still based off of the last Q&A with Dr. Boiin. Does anybody else have any other questions? Because many of these, again, are probably more for the open panel. As I'm going through them. Here's one. When will mRNA therapy be available for human clinical trials, and what might be the expected side effects?
Yeah, this is a very good question. So, I mean, it's hard to give a precise answer. Now, so there's one challenge at which this new mRNA technology, which is if you want to use it for fibrosis, is actually obviously in part to deliver it to the right place or to deliver enough of this mRNA to the immune cells so that sufficient numbers of immune cells would go there. And we also don't know how often these mRNA therapies will need to be administered. I would suggest that at the moment, based on the studies really literally came out in February of this year. And this we call it the preclinical stage, which means it's validated in animal models. Normally takes several years to go through what we call the IND enabling stage, and so which means then the FDA starts supervising the toxicology studies and so on. It is possible that due to the effectiveness and success of the mRNA vaccine, there might be accelerated procedures, but at the moment it's a completely new and cutting-edge technology for non-vaccine or non-cancer applications. So I would say I can't give a precise answer, but probably several years.
Thank you. Do you think in the next 5 to 10 years we will have a treatment for fibrosis?
So I hope so. We actually have for the KI, our target is to make an impact in the clinic. That's our hope within 10 years from science to the clinic. So I hope so. And I hope within 10 years we would have something that at least in part reverse fibrosis.
Yeah, it brings me back to a thought when in the 90s, when I first started working in research, where we were in research and where we are today. Is there any way that you can maybe give a sort of an overview of how much research has advanced since the 90s into today with the treatments that we have?
Yeah, so of course, as Francesco Boin has mentioned, we had first of all, a dramatic change in the type of treatments that are available. And we went from what we call non-specific immunosuppressants, like effective medications, but they're not targeted, they're not designed to be targeted to specific molecules, like, for example, MMF or cyclophosphamide. More, close to what we would call cyclophosphamide is more close to what we call a chemotherapy, to targeted medication, like, for example, kinase inhibitor like nintedanib. And that has been enabled by progress in our knowledge of the biochemistry of specific molecule. For example, nintedanib has been enabled by the fact that that family of enzymes, so I specialize on phosphatases, other groups specialize in kinases, and this group have progressed the knowledge of those kinases so much that we could design specific molecule to target those kinases. So definitely that has happened in the last 20, 25 years, and has really changed the way, and it's progressively changed the way that we approach therapies of scleroderma and other autoimmune disease. I think what really has been enabled in the last 10 years that we will leverage in the next 10 years is the genomic revolution. So nowadays we can sequence entire genomes for a very reasonable price. We can study, instead of focusing on a single gene, once we look at the microenvironment, as I mentioned, we look at the tissues. Nowadays, we can interrogate the whole genome. The genome expresses around 25,000 proteins. We don't have to look at one by one, but we can look at all of them, or the vast majority of them, And so this expands incredibly the selection of targets that we have, and it expands incredibly our ability to understand the complex relationship between cells and what molecules govern this complex relationship. So to repeat part of the concept that I expressed is our goal at KI is to leverage this genomic revolution that has happened, and that is a revolution of knowledge and technology for scleroderma and for the benefit of patients.
Thank you so much. And you mentioned how much help the skin biopsies were. Are you still collecting skin biopsies?
Yes, absolutely. So I know that, this is it's a very, very important point that I want to reiterate. A lot of the advancement in the scleroderma field has been enabled by patients generously donating small samples of skin. And again, this is a very generous action from the patient, but it's enabling so much in the laboratory because we have now technology that allows us to we don't need so much skin to actually gather a lot of information. So we're still doing that. The vast majority of top scleroderma scientists do that, since you cannot design a therapy that is tailored to what happens in the pathologic tissues without the tissue, as we cannot design a therapy for the patient without the patient. I think it's, I hope I convey the importance of that type of donation.
Absolutely. And how wonderful that everybody can be a part of that research that you're working on. Real quick, somebody mentioned posting the phone number again to become a patient. And I will make sure that even in my follow-up email to all of you that I provide that information, and everybody will have that telephone number. Another question, is this reverse fibrosis for all organs like lungs, kidneys, heart, or just skin?
Yeah, that is an excellent question. And the reason is that a lot of scleroderma patients, they see their skin with time potentially improving. It's not true reversal, but the skin can improve, while, for example, not in the natural course of disease, other organs will not naturally improve. So the answer I have is actually based on the study that I mentioned. And of course, our goal is to achieve reversal of fibrosis also in the internal organs. And the study I mentioned in mice using the mRNA, actually, they see reversal of fibrosis in the heart. It was a heart fibrosis model. So that gives me hope that internal organs also, the fibrosis of internal organs also one day could be reversed.
That's wonderful. Appreciate that. And I want to remind everybody, if your questions aren't specific to Dr. Bottini's talk, I'm going to address them during the open panel. And another, just a comment from one of Shirley. Thank you, Dr. Bottini, for your work and dedication. Your research is very informative, fascinating, and exciting.
Thank you.
Agree more.
Thank you. I'm inspired by the patients, so thanks for inspiring me.
Dr. Bottini, as a former patient, I'm so happy to hear from you. Are you personally accepting new patients?
Hello, it's nice to hear from you. And yes, I'm accepting new patient. I was excited to join Dr. Boin's clinic, and it's an incredible clinic, so it's really outstanding.
Yeah, and I cannot tell you how many people during our support group meetings talk about how much they miss you at UCSD. So you'll probably have some people traveling to come and see you.
Thank you. I also missed all my patients from San Diego.
Any more questions specific to Dr. Bottini's talk? If not, we're going to take a 5-minute break so everybody can, get some water, stretch, use the restroom. Just give you another minute to see if there's any other questions.
So what time are we reconvening, Tina?
5 minutes. We still have 5 minutes for Q&A, but it's okay because we can have a little bit extra time during the open panel. So we're about 5 minutes ahead of schedule.
Okay, so we reconvene with Dr. Rezaie.
Yes. So everybody will take a 5-minute break and we'll come back and we'll start with Dr. Rezaie's presentation. Thank you so much, Dr. Bottini.
Thank you.
Okay. Okay, we're going to go ahead and resume for our next speaker. And our final speaker of the day is Dr. Ali Rezaie, who will be providing a presentation on understanding small intestinal bacteria overgrowth in scleroderma patients. Dr. Rezaie is the medical director of the GI Motility Program at Cedars-Sinai, Los Angeles, and the program director of the GI Motility Fellowship Program. He is an associate professor at UCLA. Dr. Rezaie also serves as the director of bioinformatics and biotechnology at Medically Associated Science and Technology, MAST program at Cedars-Sinai Medical Center. Apart from his training in gastroenterology, he has postdoctoral training in gastrointestinal motility disorders and also inflammatory bowel disease, IBD, along with a master's degree in epidemiology. Dr. Rezaie has published more than 100 peer-reviewed papers that have been cited over 7,500 times. He also serves as the associate editor of Digestive Diseases and Sciences. His current research focuses on gut microbiome and SIBO. He is also the author of the book, The Microbiome Connection, Your Guide to IBS, SIBO, and Low Fermentation Eating. Please join me in welcoming Dr. Rezaie.
Hello, everyone. Can you hear me and see me?
Yes.
All right. So I'm just gonna, thanks for having me. And are you seeing my shared slides?
Yes, I still see the ones on the side. I think, there we go. Now you're full screen.
All right, there you go. Thanks for having me. I'm not a rheumatologist. I'm a gastroenterologist. So, and I'm going to talk about the issues that we have with gastrointestinal motility in scleroderma. So I'm going to specifically talk about the small intestinal bacterial overgrowth and intestinal methanogen overgrowth, and also the microbiome changes that we see in patients with scleroderma. So now you heard that the most critical organs that are involved in scleroderma are heart and lung, but gut, including all the way through the GI tract, is also involved. So even though it's not as critical and leading to a lot of problems like heart and lung, GI issues can become very problematic in patients with scleroderma. So just a quick overview of the GI tract. We have the esophagus that connects to the stomach. Stomach then connects to the small bowel. Small bowel is about 20 feet long. And then small bowel connects to the colon, which is about 4 feet long. And the scleroderma can affect any part of a GI tract. And also along with the lumen of the GI tract, we have the liver, gallbladder, the pancreas, and also the other salivary glands that can produce enzymes. So it's a very complex system, and scleroderma can affect any part. And specifically, we're going to talk about the effects that it's going to have on the gut microbiome. So what does your GI tract do? Let's step back and think about it a little bit from the bird's eye view. Well, obviously, it helps with the digestion. You eat the food, and its job is to just break it down so we absorb it. The second most important thing that it does is actually it harbors a gut microbiome. So there is a different world of bacteria, of viruses, and fungi inside our gut, and that they live together, and also they interact constantly with us. We do have more bacterial and microbial cells in our body than we have human cells. So in a sense, actually, we are more microbed in terms of number of cells as opposed to be human. And these constantly interact with us. And gut microbiome is the most important microbiome in our body. Yes, we do have microbiome of our skin, a vaginal microbiome, a lung microbiome, but the biggest chunk of microbiome in our body is the gut microbiome. Also, GI tract is involved in detoxifying the toxins that get into our body, especially through the liver. And also, it's a one of the biggest parts of your immune system. That's why a lot of immune therapies are associated with some side effects with the GI tract, or actually helps with the inflammatory diseases of the GI tract. Now, what is gut microbiome specifically in terms of its composition? Remember the three domains of life. We have archaea, we have bacteria, and we have eukarya. And eukarya is essentially the fungi, animals, us, and the bacteria are the single cell organisms. And then there are archaea. Archaea are older than a bacteria and the first form of life as we think of them. And they all live inside us. So if you think about it, we are not just the eukarya, we are a composition of three domains of life, including bacteria and archaea inside of us. So whenever these the balance between the bacteria and the fungi and the viruses go off track, then that leads to some different diseases and also different symptoms in patients. So one prime example of this is bacterial overgrowth. So just to give you a quantification of how much bacteria are in our GI tract, in our mouth, we have about 1 billion bacteria per ml, per cc of our saliva, for example. If you go to the colon, actually, that's 1 trillion bacteria per cc or ml of the stool in our colon. But interesting enough, inside our small bowel is less than 1,000 per ml. So the number of bacteria within our GI tract is quite variable, and there are very specific systems in our body that controls that. So whenever that balance goes away, then you may have bacterial overgrowth, meaning that now you have excessive amount of bacteria inside the small bowel. And this is not an infection. This is dislocation of the bacteria from your colon, the large intestine, back to the small bowel, and that leads to a lot of abnormalities, including the symptoms that I'm going to mention. Also, the archaea or methanogen archaea can also increase in our body, which can produce methane that can be problematic. So we hear about methane all the time, right? So the only living organisms on this planet that can produce methane are actually archaea, whether it's in a quagmire or the tar pits that you go by Wilshire, they are all produced by the methanogens, and we have a lot of methanogens in our gut, and when they overgrow, they produce too much methane, and that leads to bloating and also suppresses the motility of the gut. So now we talked about that the small bowel keeps itself relatively sterile with less than 1,000 bacteria per ml, as opposed to 1 billion in the mouth and also 1 trillion in the colon per ml. So how does it do that? Fascinating enough, it doesn't have an antibiotic or any specific sort of trick. It does it by constantly sweeping itself. It has something we call housekeeper waves. The fancy name for it is migrating motor complex phase 3, but I will call it housekeeper waves from now on. And they occur only during fasting phase. What does that mean? When you eat, the food goes into your stomach and the feeding phase starts. At that point, the stomach starts to titrate, grind the food, mix it with the acid, and then break it down into small pieces, usually about 1 millimeter. When it's 1 millimeter, then it's allowed to go into your small bowel. At that point, the fasting phase of your small bowel starts, which has 3 distinct phases. Phase 1 is silence, which waits there for the acid to get neutralized by the pancreas to become normal in pH, and also getting mixed with the enzymes. And then phase 2, which is the longest period, starts, which are non-propagating but contractions of the small bowel to essentially mix up the food with the enzyme, and then getting it close to the villi in the small bowel. If you have eaten tripe, you'll see those tiny the villi on top of it, those are the ones that absorb food. So they get it close to there, and then food gets absorbed. But after about 2 hours, a wave, a housekeeping wave starts. That starts from the beginning of the small bowel and essentially milks the small bowel at each segment, just like when you're sweeping the floor, all throughout the small bowel, all throughout its 20 feet of length, and dumps everything into the colon. And that clears the small bowel from the residual food, residual bacteria, and also the digestive enzyme. Because on a regular basis, the colonic bacteria love to come into your small bowel because they are looking for more the better source of food, and better source of food are in the small bowel, as opposed to the colon, which is now it's just all the sewage. Essentially, it's like a fecal matter. So they keep coming back, but the small bowel pushes them back into the colon. And this is very important. There are other factors as well, obviously, stomach acid, antibacterial activity, and also ileocecal valve. But what's important is that the patients with scleroderma, the housekeeper waves become weak. And that's one of the reasons that the bacterial composition of the small bowel starts to change. So how do we know this? We do have manometry catheters that measures the contractions of the esophagus, and we put it into the nose of this patient here. That's it's me here, but we advance it all the way into the small bowel, and we look at the contractions of the small bowel, and you can see the contractions. These are the housekeeper waves that I was telling you. So that's every minute, about 12 times, it sweeps the small bowel. As you can see, it moves and goes towards the colon and cleans the small bowel. And what we see in the scleroderma patient, that's this these waves are diminished. So that leads to bacterial overgrowth, meaning that the colonic bacteria comes back into the small bowel and overgrows because now it doesn't get kicked out. So not surprisingly, bacterial overgrowth, which can happen in many, many patients, but one of the diseases that is commonly seen is scleroderma. In fact, it's seen 13 times more commonly in the scleroderma patients than healthy controls, one of the highest levels that we see in any disease. So it can be seen in other diseases as well, like diabetes. It can be seen in inflammatory bowel disease. And also what we have shown actually in our research lab, that after a food poisoning, as you develop antibodies such as antivinculin antibodies, that interesting enough, there is actually a link with the scleroderma as well with these antibodies, but they can affect the motility of the gut as well. Other things that can lead to bacterial overgrowth are bowel surgeries, medications, pancreatitis, small bowel diverticulum, and also autoimmune gastritis and low stomach acid. Some of these also can be present in scleroderma as well. So there are scleroderma patients that undergo bowel surgery and patients that undergo treatments that affects the motility of the gut. So that adds extra fuel to the fire and further affects the motility of the gut. So what are the symptoms? What happens when you have excessive amount of bacteria or excessive amount of methanogen archaea in the bowel? So the classic and typical symptoms of patients are postprandial abdominal distension and bloating. Essentially, you eat, and after sometimes half an hour to about 2 hours, you start to feel bloated, full, distended. The difference between bloating and distension is that bloating is the sensation of feeling full. Distension is the visible protrusion of the abdomen. So very commonly seen. Generally, the way it presents is that in the morning you feel better. As the day goes along, you get more and more bloated as you eat. In the evening is usually the worst timing of the abdominal bloating and distension. That's the classic symptom. So it doesn't have to be exactly that way, but those are the typical symptoms. It can lead to nausea, but generally not vomiting. Vomiting can be probably associated with gastroparesis, for example, which is the stomach not being able to contract, and that's a separate dysmotility that can happen in the setting of scleroderma. Abdominal discomfort, fatigue, postprandial brain fog is a common phenomenon, and also it can be associated with weight gain and weight loss, and also diarrhea and urgency. Depending on what type of bacteria overgrows, the bowel habits can change. So if you have excessive amount of hydrogen or hydrogen sulfide producing bacteria, then that can lead to diarrhea. But if you have methane producing archaea that are overgrown, then you typically get constipation. Having said that, these are not universal rules. They do have overlap, and also it can associated with some malabsorption as well. Just quickly, how we diagnose this is that we do small bowel aspiration for bacterial overgrowth. That's one of the ways that we do an endoscopy. We go through the esophagus into the stomach and then into the small bowel and aspirate the juice from the small bowel. Obviously, it's an invasive test, but the advantage is that I can take that bacteria and look at it and see what type of antibiotic is able to kill it, and then use that specific antibiotic. And also it can help with diagnosis of small intestinal fungal overgrowth as well. But the issue with this is that the current techniques are not perfect. We're actually on our lab, we're working very hard to perfect the technique, because it has 20% contamination rate at the currently. So we're making very delicate catheters that hopefully will come to the market starting May to aspirate the small bowel. So that will help us to have cleaner samples from the small bowel. But one issue is that for intestinal methanogen overgrowth, aspiration of the small bowel is not enough, because we're not capable of growing methanogens in the microbiology labs yet. So we can't use aspiration for assessment of the intestinal methanogen overgrowth. So then we use breath testing. So just a very simple pathway of gas production by microbiome. This is essentially how the gas inside our gut is produced. I mean, when you pass flatus, this is essentially how it's done. Unless you have swallowed some air, when sometimes you burp, the gas is actually produced this way. So bacteria breaks down the sugar, and that leads to production of CO2, carbon dioxide, and hydrogen. And hydrogen from the bacteria can be used for other bacteria and archaea to produce methane, acetone, hydrogen sulfide, ammonia, many other sort of gases. So our cells are incapable of producing hydrogen or methane. So any hydrogen or methane found in our body is produced by our gut microbiome. That's why we use breath testing to see if we have excessive amount of bacteria in our gut, with measuring the hydrogen and methane in the exhaled gas that comes out of our breath. Because some of that gas gets into the blood system, goes into the lung, and those gases then we can measure in our breath. So what's the advantage of using that technique, breath test, instead of small bowel aspiration? Well, it's non-invasive. It's way much more inexpensive. And also it's the hydrogen and methane are exclusive biomarkers of microbiome, and it can tailor the antibiotic therapy for us. But one issue is that if you have fungal overgrowth, for example, you can't pick that up. And also if the small bowel is overly rapid, it can give us a false positive result. But again, this test needs to be interpreted in the setting of clinical presentation, so we understand how to interpret the test. And that's why we published the consensus how to interpret breath testing not a while back ago, to see how the test is done and what sugars needs to be used. This is an example of how breath testing is done. So you fast overnight, the day before you go on a bland diet, and then you come in, we measure the hydrogen and methane in the morning, and we check the hydrogen and methane every 15 minutes and see if we see a specific rise or not. After about 150 minutes, actually it's seeing a mild rise is normal. That's when the sugar has reached the colon, and that's essentially the late rise suggestive of colonic fermentation that is normal in all of us. But if it happens within 90 minutes, that means that now there is an excessive amount of bacteria inside the small bowel, which there shouldn't be. And that tells us that there is something going on, and we can treat patients. And this is when methane is elevated. That's what we call intestinal methanogen overgrowth. Recently published a paper that's actually is very fascinating. This amount of methane in the breath is not surprisingly associated with constipation, gas, and less diarrhea. It's also associated with the amount of archaea that are in the stool. And interesting enough, when we treat the methanogens with antibiotics, for example, we see a gradual rise every day as we give them the antibiotics. So we can even monitor how much of these archaea are in the gut. So how do we treat it? So the treatment is, first of all, you saw that multiple diseases can lead to this. So you have to take a look, make sure that there is no modifiable underlying cause in there. For example, if patient is on narcotics or opioids, they can slow down the gut. So we'll try to see, okay, if we can decrease the dose of those. However, most of the times, well, patient is on it for a reason, so we can't take those off. So we do have a specific medication that negates the effect of narcotics on the gut to help with the motility of the bowel. If there's obviously inflammatory issues of the small bowel, we try to control the inflammation to help with the motility. If patient has diabetes, controlling the diabetes better will help with the motility of the gut. But so many times, the underlying cause of the bacterial overgrowth is not necessarily can be completely modified. So what we do is that we use induction of remission, meaning that we suppress the amount of bacteria by antibiotics or elemental diet. I'm going to go into detail of that. And then after that, we maintain the remission if we're successful in induction of remission, meaning that we keep the small bowel environment less favorable for the bacteria to overgrow. And we do that by diet, low fermentation diet, meaning that diets that are not super fermentable by the bacteria, and also drugs that helps with the housekeeper waves. So it's medications for induction of remission are not perfect. And that's one very active field of research that we're working on. So their efficacy is about 51% if you pull all the studies. And there are different antibiotics that have been used. Very classically, we use rifaximin, but ciprofloxacin, neomycin, etc. Flagyl has been used in this scenario. And also the antibiotics also and positive breath tests determines the response to antibiotics, which is not surprising. And this has been shown even in phase 3 trials. That's the case. And another issue is that when you have intestinal methanogen overgrowth, the methanogens are resistant to many antibiotics, and that has become an issue. So you have to do two things. Remember, methanogens, i.e. methane-producing microbes, produce methane by using the hydrogen produced by hydrogen-producing bacteria. So if you suppress those hydrogen-producing bacteria, you decrease methanogenesis. So we do use antibiotics in that scenario, plus an antibiotic that is partially suppressant to the growth of the methane-producing microbes as well. So essentially, we double whammy them to try to keep them at bay. Having said that, methanogens are very resilient, so it's not easy to get rid of them. The one other option is actually elemental diet. Anything that we eat has three main components, right? So it has carbohydrates, it has protein, it has fat. So when it breaks down into pieces, it becomes monosaccharides, fatty acids, or amino acids, right? So they get absorbed after that. So elemental diets are diets that are those broken pieces already packaged. And then when you take those, they get absorbed right off the bat in your small bowel. So the rest of the small bowel doesn't see the food. So the bacteria literally starve to death. So their population decreases. The problem with elemental diet is that they taste very foul. They're not easy to take, and that's the problem. Having said that, they are very helpful in managing bacterial overgrowth and also other diseases such as Crohn's disease, eosinophilic enteritis, and celiac disease has been tried. So the good news is that in very near future, palatable elemental diets are coming to the market. So we will hopefully see them making some breakthrough in managing patients with bacterial overgrowth. Now, that important thing, especially in Scleroderma, is understanding that even though that you can knock it off by antibiotic, there's a high chance of recurrence because the underlying dysmotility is there, right? So that's one thing that's is important to keep in mind, as you may need multiple rounds of antibiotics despite the maintenance of remission techniques. And also you may even need chronic antibiotic therapy, which we see in some of the patients with Scleroderma. So how about the diet? Actually, one of my patients and also our dietitian got together and put together this book, which is actually not specific for Scleroderma. It was actually very specific for patients with small intestinal bacterial overgrowth. This is because the diets that generally people use for this scenario is low FODMAP diet, but the problem is that it's very restrictive, and it's and within few months leads to micronutrient and macronutrient deficiencies, which is obviously not a good scenario in somebody with Scleroderma. So we have low fermentation diet with palatable recipes that can help you at least to see, okay, what can I eat? What can I make with a low fiber content and low sugar content that is still, edible? And this is a book that I recommend. It's helpful for the patients. So what else can we do? Remember, I talked that housekeeper waves are only happening during the fasting phase. So if you continue to graze throughout the day, if you eat every hour, then those waves don't occur. So you have to give yourself a little bit of a space between the meals, so those housekeeper waves present themselves. And also when you sleep overnight, not to eat overnight. So that also helps with the housekeeper waves to regularly show up. Now, sometimes that's easier than said than done, right? Because patients with gastroparesis, we recommend them to graze throughout the day. So that's not, that can't be done all the time, but that's one intervention that we recommend. We also have medications available that helps with the housekeeper waves. This include, for example, erythromycin, which is an old antibiotic, but at small doses helps with the motility of the gut. We do have new 5-HT4, which is serotonin agonists in the gut. For example, prucalopride that helps with the motility of the gut. Octreotide is still available, very hard to get, but actually efficacy of these two medications, at least in my anecdotal experience, is better than octreotide. So just to put everything into a few messages is that bacterial overgrowth leads to myriad of symptoms and presents itself in multiple ways, and it's very common in patients with scleroderma. It can be diagnosed with small bowel aspiration or breath testing, and also now we have come a long way as opposed to 20 years ago that we would just treat one round of antibiotics, or even say that, okay, maybe this is functional and start antidepressants on patients. And we have come a long way to treat it, but there's still a long way to go as well that requires multiple routes of research. This is our team, and none of the work could have been possible without their help. And again, thank you for inviting me to this seminar.
Thank you, Dr. Raz. I appreciate this great information that a lot of people were really looking forward to. And I'm going to look into some of these questions now. Let's see. You mentioned low fermentation diet to keep SIBO from developing. Can you give an example?
Absolutely. So the idea is that you want to eat things that do not make the small bowel environment favorable for the bacteria. And what do bacteria like? Bacteria like sugar. Bacteria like carbohydrates more than protein and fat. Think about it. If you put olive oil on the counter, even if you put it there for years, there won't be any bacteria or fungi growing on it. The minute you pour a little bit of a sugar on it, the day after, there's going to be mold on top, right? So that's the environment that they like. So the foods that they classically like are artificial sugars, and I'm talking about sugar alcohol. The artificial sugars are not absorbable by us, but bacteria love to break them down. And that's one thing that we recommend not to take. Other examples are the legumes, beans, which are classically lead to fermentation, especially because of the crust that they have. Some of the vegetables, including broccoli, Brussels sprouts, cauliflower, these are classic ones that can lead to bacterial overgrowth. Although there are a lot of other vegetables that actually can be okay. For example, arugula is fine, spinach is fine, kale is fine, and also quinoa is okay, zucchini, cucumber. So there are a lot of other options that you can take, granted that you don't have any contraindication to take them if you have any other issues that can help you. Generally speaking, things that grow underground are better tolerated. Carrots, and also beet, especially if you cook them well, turnip, so that can be tolerated better. The onion, obviously, because of the fructans that it has, it's a little bit tough, but at small amounts, it's generally well tolerated, but at large amounts that can lead to problems. Proteins, meat, fish, chicken, and also clean carbohydrates such as white rice are tolerated, are better. For example, bread, we generally in this scenario, we recommend, for example, sourdough, even white bread, as opposed to multi-grain bread in patients with small intestinal bacterial overgrowth. That can lead to a little bit of a more bloating. But again, the diet for GI disorders, it's never set on stone. It's quite individualized, right? So you try some things that helps with your symptoms, and you modify things, right? So I have patients that are okay with onion. I have patients say that I can't touch onion at all, for example. So there is that gray zone that is quite individualized, and you have to figure it out essentially by yourself, and also with the help of a dietitian, by adding and eliminating foods in a systematic way to help yourself.
Thank you. Does food play a role in controlling the acid reflux issues, and does acid reflux coincide with SIB? I am on omeprazole, and sometimes it works and sometimes it doesn't.
Yeah, so that's a Complete. That would be a whole another talk. So, because what we have in the scleroderma as well is that the esophagus in some of the patients, it doesn't work as well. The reason why is that the esophagus, same as small bowel, when food goes in, it milks and pushes the food down into the stomach. But that pushing capability kind of diminishes in a lot of scleroderma patients. What happens in that scenario is that the food going down, it becomes essentially dependent on the gravity. Now, how is that relevant to acid reflux? We all get acid reflux. So on average, we get about 35 episodes of acid reflux per day. That's normal. So what happens is that when acid reflux comes into the esophagus, then the esophagus senses it and then pushes it down. So that's what's going to happen in somebody whose esophagus is functioning normally. But when it's not functioning normally, that acid comes in and esophagus doesn't kick that acid back into the stomach. And that leads to obviously reflux type symptoms, right? So another issue in the scleroderma patient is that the stomach is not, it may not be working well, right? So it's not emptying. And because the stomach is full, some of the contents of the stomach kind of refluxes back into the esophagus, which becomes a problem. So very commonly, we put scleroderma patients on antacids to decrease the stomach acid production. So even if acid comes into the esophagus to help with the acid reflux. So the pH of that content is not as acidic, so it doesn't burn the esophagus when it comes back to the esophagus. Now, there are classic foods that can lead to acid reflux. I mean, classically, we talk about alcohol, we talk about spicy food, we talk about very fatty food, and also tomato. These are classic ones that can make the contents more acidic and also relax the bottom of the esophagus a little bit more, and acid comes back up. So yes, there are anti-reflux diets that you can implement as well. And another important thing is that make sure that the head of the bed is elevated at night. I'm not talking about putting more pillows under your head. That doesn't bring up your chest. You need to elevate the head of the bed. You can get bed risers from Amazon or Home Depot for about 1 inch and put at the bottom of the poles of the bed on the top side, so you get a little bit of a 1 to 2 inch sort of gradients to help with that sort of acid to, when it comes up, to go back down when you're sleeping.
Thank you very much. What food should we eat and which should we avoid when we have diarrhea, bloating, constipation?
Well, there is no single rule. It all depends on what the cause of the diarrhea and constipation is. If, for example, the diarrhea is because of the bacterial overgrowth, then the low fermentation eating will help you. But if it's a inflammatory cause or an infection cause, well, diet is not going to help. You need other interventions with that, especially in the setting of scleroderma. You definitely need to know what is the cause of the symptoms that you're having, and that's very important. Sometimes even in the setting of severe constipation, you may get a diarrhea. So how does that work? We call it overflow diarrhea. So there's a large amount of stool sitting in the colon, and then it doesn't move, but then things have to move, right? So some of the this stool that has become like sludge goes around this big pile of stool and then leaks out, which we call overflow diarrhea. And because it's small amounts, you have to go to the bathroom multiple times, but actually the cause of that diarrhea was actually constipation. So it depends on the cause. But nevertheless, if you're thinking about bloating, and the bloating is the issue, a low fermentation diet generally helps with the bloating.
Thank you very much. Should we take a daily probiotic supplement?
So if you would have asked me 10, 15 years ago, I would have said yes, why not? But now more and more the data is coming out that actually that may not be a good idea. So now I'm going to open this a little bit further, at least in the GI field, because now in our guidelines, essentially, we recommend against probiotics in these scenarios. The main reason is that actually we don't know what we're doing when we add a single strain or multiple strains of bacteria at nuclear doses in the gut that has already have abnormal composition of bacteria. That's the bottom line. We don't know what we're doing, as simple as that. So more and more studies came out with large studies that, for example, a study called Placide that was published in Lancet, which is one of our best journals. They randomized, for example, 3,000 patients into 1,500 placebo and 1,500 classic probiotics, Lactobacillus bifidobacterium. And they followed them after antibiotics for 3 months to see if they get less C. diff, less antibiotics-induced diarrhea, or did they get benefit. What they saw is that there was no benefit in terms of C. diff and diarrhea, but what they saw is that actually it worsened the bloating. A recent study also has linked probiotics to more abdominal bloating, more abdominal distension, and even brain fog that we see, especially in the setting of patients with bacterial overgrowth. But the argument with these was that, okay, so you're using the wrong probiotics. My probiotic is better. You used the wrong choice. So the idea became, okay, what is the mother of all probiotics? What is the best probiotic out there? It's fecal transplant, right? So you're essentially taking somebody's stool and microbiome from a healthy individual, and you put it in and somebody else. So that's essentially the ultimate probiotic. But studies on that in the setting of irritable bowel syndrome, which a significant proportion of them have small intestinal bacterial overgrowth, has been all over the place. By no means they have been conclusive. And in fact, actually, the study in the US has had to be stopped prematurely by FDA because placebo in the interim analysis was superior to fecal transplantation. And the study in Denmark showed the same thing. Having said that, one study in Belgium and one study in Norway was positive, so it's all over the place. But generally speaking, I can tell you anecdotally, patients who have done this, and I've seen them in the clinic on their own, they have actually worsened in my experience. So,
Wow.
so all these evidence together have led to the fact that just empiric therapy with a probiotic is not the answer. Eventually, if we find specific pathways of what's going on in the small bowel, then we can give individualized directed probiotics to patients, but we're not there yet. So at this point, I recommend against probiotic therapy.
I'm really glad that you mentioned that, because I've always been a strong believer about these probiotics, not only in a supplemental form, but, you know, like kefir grains, for instance. Some people use, I think it's the fermentation with cabbage, and knowing that is really important, because I have never heard this before. So it's great for our patients to understand that this is basically all basic GI involvement in a scleroderma patient, not just for patients with acid reflux or SIBO. You really just don't think probiotic is the way to go for GI involvement, period. Am I correct on that?
So no, so in certain scenarios that actually they can have positive effects. So we know that certain type of probiotics are helpful in patients who have C. diff, all right, a Clostridium difficile infection, right? So to decrease the amount of reinfection, right? And also probiotics, we have good evidence in terms of, for example, the other diseases in terms of Candida vaginitis has been shown to be helpful. And those are the indications that we know. Now, if you have a healthy gut, you don't have any other diseases, well, you can take a probiotics, but the thing is that your body is going to manage. But the problem is that with patients with this motility, patients with bacterial overgrowth, now you're adding this probiotic, it's not going to behave the same as somebody who's healthy. So that's the problem, and we can't even predict how that can happen.
Yeah.
So I give you actually one example of one of the issues that we had with probiotics. There was a study called Propatria that was again published in Lancet. That was about 10 years ago. So we have patients with pancreatitis. These are patients that all of a sudden the pancreas becomes inflamed. They end up in the hospital, and it can be fatal because the pancreas essentially triggers a very acute and severe systemic inflammatory response. So these patients were randomized to placebo or probiotics, right? So at this point, obviously, these patients are immunocompromised, right? What happened was that the study had to be stopped in the middle because patients on probiotic died more. And this is not because if I'm a healthy individual and taking those probiotics, anything is going to happen to me. Nothing is going to happen to me. But those probiotics can behave differently when you're immunocompromised and your GI tract is not normal. They're living organisms. They, at the end of the day, they care about themselves, not you. So you have to be careful about that.
That's wonderful. Well explained. Thank you so much. Next question. How common are GI side effects when taking, let me say this correctly, donepezil, Donepezil? Donepezil.
Okay, yeah, donepezil. Yes.
Thank you.
So yes, there have been reports of donepezil causing sometimes bloating, constipation, diarrhea. I can't say that it's common. Generally speaking, patients who are started on this medication are on multiple other medications, so it is a little bit hard to tease out what exactly happened. But overall, it's well tolerated. But do I see patients that can't tolerate it? Yes, just like any other medication. So that's one thing that you need to talk with your neurologist to see if you have an option, or you can decrease the dose. So that's something to think about.
Thank you. I know that you talked about acid reflux, but what about how do PPIs affect digestion?
Oh, so that's a very long answer. I'll give you a short one though. Let's step back about what PPIs do, right? So on average, we produce about 1/2 gallon of acid per day. And that acid has a pH of 1.5 to 2. So it's enough to burn through a steel table or sheet, if you will. So PPIs decrease the amount of acid production by suppressing the acid producing cells in our stomach. So the acid is there essentially to break down the food and also help with the digestion, and it's sort of like helps with the digestion clearly, and also the bacteria that goes from the mouth also they die inside the stomach because of that high acidity that majority of the bacteria are incapable of tolerating them. But the good news is that the acidity of the small bowel doesn't change with PPI, because the acidity of the small bowel is controlled by the pancreas. Pancreas produces bicarbonate. So the minute the acidy sort of content of the stomach ends up in the small bowel, the pancreas pours in some bicarbonate and neutralizes that acidity. So depending on what the acidity of that mixture of food and acid, which we call chyme, is in the small bowel, pancreas produces different amount of bicarbonate. So the acidity of the small bowel doesn't change. So we actually published one big study 2 years ago that showed despite the dramatic effect of PPI on the acidity of the stomach, the microbiome of the small bowel didn't change as much, which is actually very promising. And it also doesn't affect the absorption of pH dependent medications that are absorbed in the small bowel and colon, which is also good because we use them all the time. So overall, the effect of PPI on digestion, except for the stomach that decreases the acid, is not super dramatic. And these are medications that have been around for more than 40 years in terms of H2 blockers, and in terms of PPIs that have been around 30 years. Yes, there are side effects associated with them, but remember, these are medications that that hundreds of millions, if not billions of people are on it. One of the most common medications. So yes, in that scale, there's some side effects, some minor signals show up. But among all the medications that we use in GI that have a significant amount of side effects, PPIs are definitely not on top of the list.
Thank you so much. We are going to pause right now specifically to tailored questions to you, Dr. Rezaie, and we're going to take a quick break, and then I'm going to organize highlighting all of you, and then we're going to open the floor to asking all the questions, and I'm going to do my best to address questions for all of the speakers. Thank you very much for your wonderful, very informative information. This was something that we really needed today. So thank you so much, Dr. Rezaie.
Thank you.
Doctors and Marianne, when you're ready, you can start your video, and then I'm going to start going through the rest of the questions. Okay, I'm going to go back to some of the questions that were coming up at the very beginning, and I'm going to, like I said, try to go back and forth with some of the questions. And I'm going to start with, my blood work showed positive ANA for limited scleroderma. Only symptom is Raynaud's, and was told is not full-blown scleroderma until a second skin condition appears, and reluctant to do a CT. How can I convince my rheumatologist that it's not true based on what was discussed today? Dr. Boiin or Dr. Bottini?
Yeah, I think we addressed already this question early on. They were asking about, do we need to do a full workup if we have minimal symptoms, particularly early on? And we emphasized that it's very important to look carefully for any evidence of organ involvement. So a CAT scan is a little bit, still under discussion because it's radiation. So we want to, but I think the consensus is moving that very likely in the near future, every scleroderma patient at baseline, at the time of diagnosis, will have a CAT scan of their chest. Because we know that it's very true that patients with more diffuse scleroderma, have more likely lung involvement, but also patients with minimal skin disease still can develop, pulmonary fibrosis. So I think, the answer, as we said before, is absolutely it makes sense at least one time to do a full workup and then monitor over time with the testing that we recommend.
Thank you. Can you speak on rituximab therapy added on with CellCept?
Yes. So I didn't put it on the presentation. There's been a recent trial called Rezaie trial, which was done in the UK, and they compare cyclophosphamide to rituximab, and didn't show that rituximab was superior, but it showed that it was equally effective in stopping progression of lung disease. So definitely, this is just recent, just came out. It was presented actually in Philadelphia last week at our kind of national convention. So I think we knew it because we were using it already, but at least now we have some confirmation. It will not be enough to have the FDA to approve it. So still the challenge will be getting the insurance to cover for it. But in our sort of approach to treat lung disease in scleroderma, if for any reason the current drugs do not yield the expected benefit, or if the patient cannot tolerate certain medication, definitely rituximab is a very good drug that we can use for lung disease. Also because it's effective for inflammation in the joints and is effective for inflammation in the muscle. And sometimes in our patient population, there are overlapping, as we discussed, complexity, right? So the lungs are affected, but there is evidence of inflammation in the joints and the muscle. So using some strategy with these drugs that have multiple function, I think can be beneficial. So it's definitely something that we use regularly as a second level agent once we exhausted the effect and benefit from the first line agents.
Good to know. Thank you for explaining that. This would be either for Dr. Bottini or Dr. Boin. I forgot to say that maybe I should have people specifically addressed with your name, but I do believe between the two, you guys can decide who would be more comfortable or would like to answer. Is there a medication that prevents oral problems associated with scleroderma?
Dr. Bottini, do you? So oral problems, I can quickly say, we can give an hour talk on what happened in the mouth. So there are many different things that can affect the mouth of a scleroderma patient. First problem, saliva production may be decreased. So we call it secondary Sjogren or like Zika syndrome. It can happen that the mouth becomes overtly dry, and that leads to ulceration, fungal infection. So definitely, that's if it is the case. We have a full handout that we give in clinic to how to manage with biotin product to create some coating that protect the mouth. Second, gum recession. That can be very dramatic. A lot of patients, even early on, start to have loosening teeth, the gum, and we feel that that's a combination of scar tissue, but also the blood supply is decreased and the bone get reabsorbed. So there we recommend aggressive, assertive periodontal care. Absolutely. You cannot allow infections or other things to accelerate that process. And we believe that on the long run, vascular therapy will help slowing down that type of problem. And then obviously there is the acid reflux, and we heard a little bit about it, that can be silent. It may skip completely the sense of heartburn, but the patient report like sour taste in their mouth, and that can erode the teeth, can create a lot of problems. So we pay attention if we have signs when we examine the oral cavity for silent reflux that can certainly accelerate problems. So, it's a whole world into the mouth, and definitely important piece of care that we deliver.
Thank you very much. Do you recommend yearly echoes and PFTs for those diagnosed with limited systemic scleroderma?
Dr. Bottini.
Yes, I think that's absolutely yes. I hope Dr. Boin, you agree. Yeah.
Yes, and interesting. I've come across many people that think when they are given that diagnosis of limited systemic scleroderma, that it means that their disease is limited. And it really goes to show you how important it is to see a scleroderma specialist that can really break that down and explain it, because these are gold standards in scleroderma, and these are very important tests. So thank you for confirming that.
Absolutely.
I have ILD and Raynaud's. Prednisone helps with body stiffness and pain. What type of scleroderma do I have? My doctor hasn't told me.
Yeah, that based on only that, you cannot say. The question, Raynaud's and those are pretty much present on most of the patients. The fact that you benefit from prednisone, that doesn't tell us much. Everybody, if you give prednisone, feel a little boosted, a little better mood. If it is some amount that is not too high. And then when you taper it down, feel a little achy and uncomfortable. We don't use a lot of prednisone in scleroderma. Part of the problem, there is an association for the renal complication called scleroderma renal crisis. So even when there are inflammatory features, we use it in moderate to mild quantity. But we do use it when we need it. So again, as I mentioned, there are patients that have overlap features for inflammation in the joints, inflammation in the muscles. So sometimes prednisone is beneficial, but always to keep it in moderate quantity, only the minimum necessary. Because again, there are long-term complications, the cataracts, osteoporosis, the muscle get weaker just because of the use of prednisone. So we have to be very careful. So it's not something that we use generously, and it does not tell us anything more. We need to, look at you, assess all the different organ involvements to give a better definition of what kind of scleroderma you have.
Thank you. Is keloid scarring related to scleroderma?
Yeah,
that's yours.
Yeah, that's a very interesting question. So it's not the same mechanism. However, some of the processes that I mentioned in my presentation, like for example, the fibroblast, it's kept activated by the scarring, seems to be active also in keloid. So several laboratories that study the scleroderma fibroblast also like to compare it with keloid fibroblast.
Thank you very much. Let's see. I'm just going down the list here. Is this reverse fibrosis for, oh, I already asked that. We already asked that. I apologize. Let me keep going.
Yeah.
Is rituximab as effective as nintedanib, if I'm saying that right, and tocilizumab?
It's, as I mentioned, both nintedanib, so OFAV, and tocilizumab, we're using specific group of patients, or there's not a trial at the level of those that have been done for these drugs. So rituximab has been studied only in comparison with cyclophosphamide. So there is no head-to-head trial that can tell us whether it's more effective or not. And currently it's used as a second-line agent after we did not achieve goals with the first-line agents, which are basically the CellCept, and now we have the OFAV and the tocilizumab.
Thank you. This question, I have VA, can this help get me to pay for a study? I don't believe that most clinical trials are having you come in where you're paying like a clinical trial, and like a patient going in a clinic setting versus a research setting. And so I don't know if that really,
Marianne,
right?
Marianne, are you connected? Do we, yeah, there you are. Are we charging our patients for research?
No, so all of the, if you were to join in our clinical trials or cohorts, everything would be covered by the studies.
Right, and there is also sometimes some stipend. So usually they try to make also worth investing time and participating. So
yeah, even things like parking, some of your travel expenses to make
Correct.
it easier, because they there's big expectations on keeping up with the study timelines. Thank you for explaining that. Let's see. Dr. Rezaie, this is for you. I have a patient who has impaired swallowing muscles from scleroderma and is completely dependent on tube feeding via gastrostomy, if I'm saying that right, excuse me, tube for nutrition. Is there a specific type of feed formulation that you would recommend? And would you recommend an intermittent bolus feeding with at least 5 hours fasting versus continuous tube feed?
That's a good question. So again, depends on the GI symptoms. If the bloating or abdominal pain or constipation or diarrhea is not an issue, then you can use the general tube feeding sort of guidelines in conjunction with the dietitian and also your small bowel expert. But if you have bacterial overgrowth or abdominal distension, so one option is that one of the tube feeds you can try elemental diet for the tube feed. Then actually that does help with the bloating in a lot of patients. So the elemental diets that are out there for tube feeds, multiple companies make it. The most famous one being, for example, Vivonex, made by Nestle. So that's one option. Again, that can be discussed with whoever is dealing with ordering the tube feeds.
Thank you.
Good question.
Thank you. For a non-SIBO patient, what are you recommending over the counter for treatment of diarrhea or bloating or constipation?
So if it's a non-SIBO patient and it's a very mild, so definitely for treatment of transient diarrhea, Imodium at small doses is okay. And if their bloating is not an issue, you can even try some fiber supplements that can definitely help. In terms of constipation, again, my favorite laxative for transient constipation is somebody that it doesn't have severe symptoms, remains Miralax, which is the polyethylene glycol 3350, which is essentially a non-absorbable powder by you or the bacteria. It goes in there, absorbs some fluid, and that makes the bowel moving. That's the same compound that very commonly we use it before colonoscopy to clean out patients, and that's a very safe drug. That's why we can use it in like super large doses prior to colonoscopy. So small amounts that can help with the constipation. The only problem with that is that some people don't like the goopiness, if you will, that it gives to the stool, and it's hard, sometimes becomes hard to wipe. So in that scenario, you can try your magnesium compounds. There are multiple magnesium compounds that can help with the bowel movements. Magnesium citrate, usually it's too powerful, so I recommend magnesium oxide or Mag-O7, which is ozonated magnesium. That is generally mild enough to help with the constipation without causing cramps. So those are the first go-to sort of approaches that I try.
Thank you very much. That's a great explanation. Dr. Bottini or Dr. Boin, I was diagnosed with Sjogren's 16 years ago, diagnosed with Scleroderma in 2019. I take hydroxychloroquine for both. My rheumatologist has not discussed my medications or changed them. I don't know why I'm taking it. Can you explain how Plaquenil works for my diagnosis?
I'll let Dr. Boin also comment more, but we don't really prescribe Plaquenil specifically for scleroderma, except if there is a joint involvement, or it's more on an arthritis medication. So it doesn't have a specific mechanism of action that it would prevent the progression of fibrosis.
Yeah, so Plaquenil is a mild immunosuppressive drug, very mild. It's one of the mildest, and so it's used, for example, in lupus, or just to keep the immune system at bay without overtly immunosuppressing the patients. In Sjogren's syndrome, it's used both in patients who develop joint disease, or it's shown some benefit for the neuropathy that can be associated, peripheral neuropathy, like sensory, like pins and needles that some patient with like true primary scleroderma develop. But as Dr. Bottini said, there is no role in scleroderma unless there are overlap features. In that case, it can be used. What I like about this question is that whenever you use a medication, even an aspirin, number one, there is a price you pay. There is always a price tag for any medication you use. Number two, you need to have a target. So it doesn't make sense to give medication because you have a disease without knowing what are you targeting. In scleroderma is a classic example. We don't give, Celsec because you have scleroderma. We give Celsec because you have lung disease or skin disease. We give you, amlodipine to treat the Raynaud's. So we have to have an endpoint. Otherwise, you can be on a medication forever and not exactly knowing, is it helping, not helping? And eventually there is a price to pay. So definitely you have to put your doctor on the stand and say, hey, just tell me why you're giving it to me. How is that helping? I haven't seen any difference. So just be your best advocate on this. I always, have this chat with my patients. Very important.
You just took the words right out of my mouth, and I really appreciate you saying that, because they needed to hear it from someone like you. And this happens all the time. You need to be your own advocate and ask the questions. Demand to understand why you're taking these drugs. And oftentimes when it's not a scleroderma specialist, this is what happens. And this is why it's important to engage in these types of forums and learn the information and take notes and go back to your doctor, you know, with, like I said, your scleroderma suit of armor, ready to get the answers that you need and deserve. So thank you for that. Are there any presently, are there any controversial alternative or holistic medicines or therapies that have shown any potential in the future of scleroderma treatment?
Well, we don't want to talk about the controversial, because those by default are not something that we endorse or we will recommend. There are, in the media, there are a certain number of drugs or treatment, I don't want to get into that, that are proposed as the famous holy grail for scleroderma, but most of them have not been shown benefit or to be applicable on a large scale. And I actually, in some cases, had delayed proper treatment, or, you know, in patients who need it. In terms of alternative or holistic, you know, that's a generic term, you know, and there are like many different approaches to help scleroderma patients. You know, I can just mention acupuncture. Acupuncture is an alternative practice, and I've seen patients who reported benefit, for example, for the hand involvement of scleroderma, for neck kind of contracture. Some patients report benefit on Raynaud's, and some patients even reported benefit of the acid reflux. So I don't have experience personally to say, oh, I know exactly how that should be done or for which problem, but I definitely don't discourage something that the patient tells me is being very good to them. There are many other supplemental things that have been proposed. We like antioxidants because we do believe that fundamentally scleroderma is a vascular disease, and anything that can help the health of the lining of the blood vessel can be beneficial. So any fish oil or other antioxidant compound, I think taken on the long run can be helpful. I know that there are over-the-counter preparations that increase their promise to increase motility. Dr. Rezaie can certainly comment on that, like iberogast, all these herbal preparations that somehow have been tested. But I don't think we have trials. I think it's more anecdotal experience. And I don't know, again, before I turn it to Dr. Rezaie, but for the major aggressive manifestation of scleroderma, I'm not aware of anything alternative that can substitute the assertive approach that we have to implement early on, early diagnosis, early treatment, assertive treatment to prevent that underlying damage to become established and irreversible. So they can help, they can complement, but I don't think they can substitute the main therapy. Dr. Rezaie, for the GI standpoint, what would you say?
Right. I really like what you said there, because from the GI standpoint, let's talk about bacterial overgrowth, right? So if you leave bacterial overgrowth untreated, the consequences are not bad as like lung or heart disease associated with the scleroderma untreated. So if you try something that's because there are treatments, as you mentioned in your talk, that can help patients. So I would not delay starting those medications. Having said that, in the GI world, probably more than any other sort of discipline, we do have the presence of supplements that can potentially help with, let's say, talk about the blood bloating, for example. There are compounds, iberogast that you mentioned, or compounds such as the IB Guard, which is a peppermint formulation that opens up in the small bowel. And interesting enough, there are a few randomized controlled trials that showed positive promise with these medications. Generally, they're not that potent, but the good news about these is that at least they have been shown to be safe. So I commonly use that as an adjunct therapy, as you mentioned, for the treatments that we use to help patients. But yes, as some of the treatments, as we talked, such as probiotic, got busted in terms of response, but some of the treatments have shown some promise. Yeah, so just make sure that you read upon what you're taking and search the evidence behind it before committing to some sort of medications. A prime example of it is that very commonly used supplement, a laxative called Cascara. That's if you go to, for example, Middle East or South Asia, it's a very traditional laxative, but in long term, actually, it paralyzes the bowel. This is to a point that FDA has banned it in supplements. So they can have severe side effects. So you need to do your work, but some of them, even in randomized controlled trials, are showing some promise.
Thank you very much. Is there any clinical trials for severe skin involvement in finger contractures, or is there any type of surgery for finger contractures? Dr. Boiin or Dr. Bottini?
Yeah, I take this one. So unfortunately, in 2020, 2021, we had 6 clinical trials that failed to treat skin disease. So in the big kind of community, there is a moment of pause to target skin disease. People are more focusing, industry is more focusing on lung disease in scleroderma. And so there are not many active trials. Actually, there are 1 or 2 basically. It remains an unmet need, and I'm sure we're gearing up to get new compound, new drugs that will go back to treat the skin disease. The major problem is being how you assess response on the skin. And as you know, when you come to our clinic, Dr. Bottini and I like to pinch people for a living. That's how we measure how severe, in different areas of your body, how severe the skin disease is. But when it comes to what we know is that it gets worse. Remember that trajectory I showed you before my presentation. The skin tends to get worse at the beginning, then sort of plateau, and then it gets better. So depending when you enroll into the trial, you may only get better, and you may get better on your own. So we need better ways to measure. So we are looking, and the work that, for example, Dr. Bottini and his team is doing is very critical because, for example, we may be able, by doing skin biopsy, to measure the response in a more precise way, and knowing that the drug is making a difference that on the long run will be beneficial. So I think for skin, in the next few years, there will be more trial. Right now, we don't have many. It's more focused on the lung. Regarding the contracture, so the bottom line is the hands, even if everything else soften, the hands oftentimes don't improve. Unfortunately, partly because you use them all the time, you traumatize them, damage can become more permanent on the hands. The bottom line, you want to preserve your opposition, finger opposition, ability to pinch to hold object. As long as you have that, we discourage from surgical intervention because the surgery itself may trigger more scar tissue and may not be a good outcome. The best we can do if the fingers are crooked is to straighten them out in a fixed way. So we are attentive. If there is one dominant finger, let's say the one finger is, the other are relatively okay, one is really damaged, you can work on that finger. Sort of you have to do a major surgery, fuse the finger, and then make it straight so you can have opposition. So that's feasible. But imagine that all the fingers are affected. Some of our patients, unfortunately, because the disease was so active early on, you cannot, you will not find a hand surgeon, hand specialist who is willing to do the same procedure on every single fingers. What we recommend is stretching every day, a lot of prayers, a lot of stretching. You're not breaking anything, and you're trying to counteract that constant process of shrinking that the scar tissue does. There are some rings you can buy online. Some of them are beneficial to prevent contractures, but the stretching is important. That's where, there was a question on the chat about hand therapy, occupational therapy. We are thrilled to work with occupational therapists, deep tissue release, strategies to prevent the contractures. That's areas where we can definitely do studies, even if they will not take a long time. And I conclude there was a trial that failed. They used stem cell, right? They used fat from your own body. They have a magic recipe to get stem cell out of the fat, and then they re-inject it with the idea that you would go into the damaged hands and you're gonna increase the function of the hand. The trial failed, meaning that, again, we are far from using these stem cells as a way to regenerate damaged tissue. But there is still work on that. We're still working. Can we sort of figure out a way, a little bit what Dr. Bottini was saying, is one thing is just to stop progression, but the other, can we actually break down the scar tissue? Can we reverse it? And for areas like the hand, that would be really critical. And I know there are companies that approach us to figure out ways to target precisely the hands, which is kind of interesting because, you know, you say, oh, how about the rest of the body? Yeah, but the hands are so important. And actually, we will give a talk about the hands in scleroderma in the future.
I want to add that we remain, I mean, like at the KAI and the scleroderma program, we remain extremely interested in applying anything that we find for fibrosis reversal to the skin. And you know, want to highlight also what Dr. Boin just said, that we remain interested also in topical application. There are challenges with it, but topical applications to the hand to slow down progression of sclerodactyly, since, as Dr. Boin said, this is a manifestation that it doesn't, you know, reverse by itself or remodel by itself. Yeah. So we remain very interested in that area.
Thank you for mentioning that. I really appreciate it. This is such a important area, and a lot of people don't know about it. So you covered a range of things when answering that. And I want to go back to what you said, Dr. Boin. He and I have talked about this, everybody, about him doing an additional talk in the very near future, specifically on hands, which is a plethora of different areas of the hands. And it'll be a very a well-informative talk. So I just want you all to keep that in mind. I like this question. Can morphia, mild Raynaud's, and major skin issues, but negative ANA, progress to systemic scleroderma? If so, what should we look out for or test for? Does your clinic support morphia research?
So first of all, for the audience, morphia is also a variant of scleroderma, and it's called localized scleroderma as opposed to limited. So limited and diffuse scleroderma means systemic disease. It can affect the skin, but also internal organ. But there is a variant called localized that usually present in patches of thickened skin in different part of the body or in linear distribution. And that's called morphia. You know, the nickname is morphia. So this, differently from the systemic type of scleroderma, it does not usually affect internal organ, you know, vital organs. It's a disease that oftentimes develop in kids. So as they are still in the development age, it may impact how well, for example, a limb grow, or they can create asymmetry in the body because the scar tissue compress the part of the body that is developing. So it can have disfiguring outcome. In adult, it may be just superficial skin involvement, and chances that transform or progress into the systemic form is very low. It's estimated 5% or lower. So we treat them as two different diseases. We do see morphia, or particularly complicated morphia. Oftentimes they're managed by dermatology, but we do see significant morphia in our clinic because sometimes these do require immunosuppressive treatment to stop. We are not doing currently research, but as we will develop our research program, I'm sure that having also that type of skin fibrosis as a comparator to the diffuse skin fibrosis can be of very good relevance to the type of program that we will develop, project that we will develop. So stay tuned on that for sure. We will consider that.
Yeah, I confirm we are interested in samples of morphia.
Yeah.
That we want to study in parallel to the diffuse and limited.
Wonderful, thank you. Dr. Rezaie, this is for you. What about prebiotic diet versus probiotic diet?
So prebiotic, so the difference between prebiotic and probiotics are bacteria, living organisms that are packaged and you take, whether it is as a form of supplement or inside the capsule. Prebiotics are essentially the food that you need to, at least in theory, fertilize the bacteria to grow further, right? So, and that's the prebiotic. It's usually the most classic example is the fiber. Now, symbiotics are the mixtures of probiotics and prebiotics that you take, and that's another option. So now, if you think that the probiotic world of research is confusing and controversial, prebiotic is even worse because now you're giving the fuel for a bacteria and you don't even know what's going to grow. And that's actually a field that is actually even less attention has been paid to, because when you fertilize a lawn and you don't put the seeds on it, well, you don't know what's going to grow. So that's going to be a little bit even trickier. So that's another field that we need way more research before we make even a simple recommendation whether they need to be taken or not. But remember, on a regular basis when we eat, a lot of prebiotics already exist in our food. We don't necessarily need to add extra prebiotic to our food to potentially or theoretically improve the good bacteria to grow, which is not easy to do.
Thank you. Well explained. Another one for you, Dr. Rezaie. Would Botox injections help with gastric reflux?
So gastric reflux, I assume gastroesophageal reflux, which is when the contents of the stomach come back into the esophagus. In the scleroderma, the sphincter that connects the esophagus into to the stomach is actually weak. And that's the problem. We use Botox when the sphincters are too tight. For example, when the pylorus, which connects the stomach into the small bowel, becomes too tight, or anal sphincter become too tight, and then we use Botox in that scenario. In cases that the sphincter is weak, where the esophagus is connected to the stomach, which we call lower esophageal sphincter, putting Botox, if anything, will make things worse. Having said that, in terms of gastroparesis in the setting of scleroderma, if we think there is a spasm of the pylorus, which is the connection of the stomach to the small bowel, we do have some preliminary, without any randomized controlled data, of putting Botox in that sphincter and relax it to see if the contents of the stomach empties and make things better. Having said that, the problem with Botox is that just like the Botox that goes under the skin and to get rid of the wrinkles, the effect is not a long term, right? So it wears off. So that's one issue with the Botox.
Thank you very much. Dr. Bottini, where did it go? This one's for you. I liked hearing from Dr. Bottini. Do they have a free clinic, or how does his office work for patients?
So I'm seeing patients in Dr. Boin's Scleroderma clinic, and so you can make an appointment with me using the same phone number that that Dr. Boin showed. I think Marianne showed there.
Thank you. And I don't believe that there's any free clinics. I think the closest thing that anybody can get to being able to see a physician outside of your network would be if you met criteria sometimes for these great clinical trials. But I don't believe that UCLA, Cedars, or most hospitals have these free clinics. Any comments, guys?
Yeah, so we do have, there are some free clinics clinic for underinsured or uninsured patients that we attend to as a division of rheumatology.
Nice.
Which can give access to our faculty, to us as well. One clinic is at the Saban clinic. It's a clinic that contract with all the healthcare network of patients who are on medical. And so you need to have criteria, obviously, of being underinsured or into this kind of protected system. And through that clinic, then we provide our rheumatologists go there and see patients. We are working on identifying patients who have absolutely no insurance, in a certain kind of threshold, and to establish an uninsured clinic here at Cedars-Sinai, but we don't have it yet. And finally, there is a clinic/shelter in Venice. It's a free clinic in Venice Beach, where but there obviously it's just our fellows who attend, and some of our faculty also supervise and participate. But I would say that there may be in the future opportunities. We just have to have the institution to support that and to be supportive of charitable type of clinic that I think will be relevant, because we serve a large population that you know, is underprivileged and will need our support as well. We are committed to that.
Thank you
Just a
for letting
question.
us know about that. And I would like maybe after, at some point, I can revisit this with you and be able to supply some of this information to some of the people that are here today, so they know where this Venice clinic is, because even though it's not one of you, these fellows have trained under you, they understand the disease, and they can probably help identify, and maybe from there patients can see if they would you know, meet criteria for studies or have an opportunity to see somebody moving forward, as well as the Saban clinic that you're talking about. And it's good to know that in the future you're working on another clinic for some that might have need the financial assistance. So really great information, and I appreciate learning that today. We are out of time. It's a minute before 12:30, and I am going to compile the questions and try to get a feel for the ones that we weren't able to answer today, and see if I can share them with the doctors. And when they have time, perhaps they can give me a little bit of feedback on them, and I can share them with everybody in a follow-up email. But we have run out of time. It's now 12:30. I'm going to come back on camera here.
We are sharp on time, which is
Yeah.
remarkable, Tina. You did an amazing job keeping everybody on pace. Unbelievable.
Thank you so much. Well, this has been absolutely wonderful. I can't tell you how much we appreciate the four of you taking time out of your schedule to be with us on a Saturday. From my heart, really, we appreciate it. Our families appreciate it. You're really helping them be a better advocate and really understand these different facets of the disease. So thank you again for your time, and thank you everybody that took time out of their day as well to attend today. Many of you I haven't met before, but I recognize your names from Facebook and the different platforms that we have, and we're here to support you as much as we can. So thank you everybody very much once again.
Thank you so much.
Thank you so
Bye.
much.
Thank you so much.
Thank
Happy
you.
holidays.
Thank you. Bye, everybody.
Bye.